Yeah. Wait, I have to confirm this. So, Valia, thank you for the introduction, for the very nice words. So, yes, indeed, I'm working with electrical stimulation since 92. I started to build up the service in the Swiss Paraplegic Center. And so I will now share my screen that we can directly jump into the talk. I would like to ask you, you can please ask at any time questions. If I say something that you can't follow, don't understand, want to know more in detail, please ask. And if I don't see that somebody wants to ask, please interrupt. Because when you're talking and have to have a look at who's raising up the hands, that's a little bit difficult sometimes, and I might miss it. Please show up, ask the question, and you are all visible. I enjoy this because if you are doing online teaching and you are looking only to names, that's for me, it's like, okay. So it's nice to to see you, to get a little bit in contact. We will interact. We have question and answers. We have a discussion in between. So I'm really looking forward to talk to you. And I appreciate, I saw the list of participants, and I think it's a great opportunity that you are such an interprofessional course that you can share your knowledge. And I really enjoy it now to talk to you. And let's try to share. It should work. Let's have a look. That's it. So you should now see my screen, hopefully.
Yes.
And then I start the presentation. And it should also be
yes, perfect.
Possible to see. Okay. Good. So we will talk about functional electrical stimulation, neuromuscular stimulation, and long pulse stimulation. And you will get more in detail what is what. So let me see how I can go on now. So as Valeria told you, I'm working in the International AVS Center in the Swiss Paraplegic Center, Notwil, and we have at least 3 parts in our department we are dedicating. So we have, first of all, the treatment, then we have the research and the education part. So that's because my philosophy is that a good research can be made from clinicians when they get directly the questions out of their clinical work, and that they can bring back the knowledge of research, the evidence back to clinics that patients might benefit from it, and that you can really transfer the results of research into clinics. And if there's something new, then you should bring it to the community. And to the community, that means clinicians, researchers, and teachers, wherever, everybody who somehow get somehow in contact with the topic of electrical stimulation and neuromuscular diseases or spinal cord or stroke patients. So in my talk today, I will, of course, my major population are spinal cords, but I also want to touch a little bit stroke and other neurological diseases. In my outpatient service, I see all kinds of neurological diseases, and even some orthopedics send patients to us to stimulate after surgery muscles that are not well received by voluntary control, regardless that there is, or without a neurological defect in the system. So, and if you look to the content for today, for the next hours, so I want to focus on the principles of electrical stimulation, just to warm you up a little bit. Then we go into neuromodulation and motor learning. And then in this field, we want to have a look in improving and supporting of function in different ways. When we are talking about electrical stimulation, then muscle fatigue is something we should a little bit be aware of. And at least I give you some examples in terms of artificial breathing, or how you can support airway management in people with electrical stimulation. Then a little bit my research focus, that electrical stimulation can be used for diagnostic, prognostics and treatment with and without electrical stimulations. And finally, I want to give you some final remarks, inclusively explaining your assignment for this lecture. So, and as I told you, feel free to interrupt me. Good. As I a little bit focused before, treatment and transfer into clinics is, in my point of view, a very crucial aspect. I read so many research projects and articles, and those research is really great, but they are kept as research projects, and they are not very well transferred into clinics. And if I look to our center, I even can see in some groups doing good research that it is never transferred really good into clinics. And so my initial question was, how can I guarantee to do so, that it is really implemented into the clinics? And therefore we have this little research road, I would say. So first of all, I think it's quite crucial that whatever you do, you have to have a solid theoretical background. You need some diagnostics, and if you have those both, you can start to perform research. And for research, it is quite crucial how research is set up. It might be deductive or inductive. Then you can plan a study and get some results, bring the results into clinics, but then it's quite crucial that you do a verification process of the effectiveness in the application of your new results. And if you see that it's not really working, then be critical and try to reformulate your research question, or continue your research, or continue your treatment and prove it again. And if you have some evidence, then bring it systematically into clinics. And then we see this light at the end of the road, and we can improve and bring best treatment, at least to our patient population. So electrical stimulation, and I'm sure most of you know this, but I want a little bit as a warm-up to talk about it. So I'm mainly talking about surface electrical stimulation. So that means that I create electrical field under the electrodes I put on the skin. And so there are two ways that I can create a muscle contraction. That's first of all, I can provoke an excitation of a nerve, or I can directly stimulate the muscle. And in choosing the parameters, the pulse duration or pulse width is really crucial. So in the spectrum of microseconds, I'm exciting the nerve. When I change to milliseconds, and so microseconds and milliseconds, I have not to tell you, there's a huge distance in between, a huge range. Then with milliseconds, you are eliciting an action potential directly at the muscle. So the response is quite the same. You see a muscle contraction. But once it's via nerve, and one is via muscle. And why this is so important in the clinical application, we will go really in detail of it. And here you see this excitation curve, and you see how the short impulses are eliciting a nerve and what a muscle needs to have for getting a muscle contraction by stimulating directly the muscle fibers. So, big difference in between both methods. And so there is a background of it. So the excitability of nerve fibers is earlier than of muscle fibers. And when we are talking about values, a nerve fiber, you see it here, is excitable from 50 microseconds on. That means 0.05 milliseconds. And muscle fibers are excitable that from 10 milliseconds. So here it's the first sign that you can test with electrical stimulation if a muscle has signs of some denervation or degeneration. And you will hear more about it. Oops. No. So please, that's some important for me. I will come back later in this morning. Keep in mind, here you see electrical stimulation can be used as a diagnostic tool. So what kind of alterations are important in the clinical application of electrical stimulation? So a good evidence is that power output and torque of muscles or muscle group can be increased by setting up a proper stimulation protocol. Also, the fatigue can be reduced. That means that you can apply stimulation after good training over a very long time. And we know it from the cycling, and especially when we go into competition, as it will be done in the cyclothlon. So the resistance can be increased, and that is quite important for neurological diseases, that disuse and denervation atrophies can be reduced, or even denervation atrophy can be converted into a normal muscle morphology after a certain time. But of course, if you stop stimulation and the muscles, either by using nerve or muscle stimulation, are not able, or the central nervous system is not able to take the function over, then everything by stopping the stimulation will be reduced again. And in the process of neuromodulation, nerve sprouting is activated. So there's quite good evidence of this. So we are playing with parameters in electrical stimulation, and I think that is quite important. And there I want really to talk with all my colleagues from the therapeutical areas listening here. So I see a lot of therapists and clinics using stimulators, and they look into the program, and there's very well written increasing muscle force or rehabilitation or increasing circulation. And then you push the button and the program in the background is working. And you don't know what this program is giving you. You only see mostly the amplitude you can increase. But electrical stimulation, to be effective, is really more than pushing a button of a stimulator in a pre-programmed stimulator. So I'm always very keen on having stimulators that I can program by myself. And by doing this, the definition of the certain parameters should be known, and that is quite good for knowing how the amplitude should be or what the amplitude is doing in a muscle. So the amplitude is the positive relation to torque by recruitment of additional motor units, and you see it here. If you have a low amplitude under your electrode, and always under your electrode where the center of excitation is, then you see you reach only a few or not so much motor units. It's not necessary to reach them all the time, but depending on your goal, and we go later to it. So by increasing the amplitude, yes, you can increase also the numbers of motor units. And there you see that that's the first, if you do the first transfer to a clinic setting. So there's a difference in the amplitude by stimulating small and big muscles. The pulse width is the positive relation to torque by increasing the activation of the motor units. So if this field is actually this area and here is at least the most important, you can enlarge this field by going up with the amplitude or by the pulse width here. And so you create bigger or larger electrical field to get the stimulation. At least we have the frequency, and the frequency is the positive relation, and torque is increased per active muscle area. And at least the frequency is this parameter that is important when we are talking later about muscle fatigue. So fatiguing you can't, or very less by changing these parameters but by changing frequency to high in a non-trained muscle, you can really fast fatigue a muscle. Good. Coming back to the frequency is at least responsible for the fusion of a muscle. And so from 7 Hertz on, we get somehow a tetanic, somehow a tetanic contraction. And it's not stable. You see a trembling in a muscle, but from 30 Hertz on up, you get a quite good fusion and a stable tetanic contraction of a muscle. And a stable tetanic contraction of a muscle is important when we are talking later about using electrical stimulation in function. That means in walking or in standing activities, or if you want to use your upper extremity for holding objects and combine it with electrical stimulation, then a trembling in a muscle is not useful to put this in to the function. But however, a muscle has to be trained up, and depending on the time of the lesion, either a peripheral lesion or a central cord lesion, that means the muscle has to be trained, and sometimes we have to go through various frequencies to train a muscle. Because remember, I said frequency is responsible for muscle fatigue. Good. By creating a stimulation protocol or tetanic contraction, our goal is to mimic an as physiological contraction as possible. Of course, we are doing at least artificial contraction of a muscle, but if you look to the chemical process, to the electrical chemical process, what is happening in the central nervous system, then the elicitation of an artificial contraction by applying electrical stimulation is almost similar to the physiological ones. And therefore, it's also important to mimic as best as possible this contraction. And normally you do a ramp up, a plateau, a ramp down, and there you get the best contraction or the best more or less physiological contraction you can get. After this, you have enough time for recovery, and then you are applying again this duty cycle, this on time. And to get less fatigue over a certain time, you should have a 10-second on time and a 10-second off time in the beginning when you start with electrical stimulation. So far so good. That's the duty cycle. So I'm always talking about the electrical stimulation via muscle and via nerve. And you might ask yourself, okay, why is she talking about the two methods? Why is it important for applying? So that's important because we are dealing with two kinds of lesion in neurological diseases. We have an upper motor neuron lesion and we have a lower motor neuron lesion. And so by getting back to some physiological parts, so the upper motor neuron, as you see here in this area, is from the gyrus praecentralis over the pyramid tracks to the motoric anterior horn cell here. And the lower motor neuron, here is the crucial part, is from the anterior horn cell of the spinal cord, and that goes via the ventral roots of the spinal nerves into the peripheral nerves to the motor end plates of a muscle. So from here to here, we are talking about a lower motor neuron. Here is the upper motor neuron. And so if you rewind, or one of the first slides you saw, we have the two ways of stimulation that we can directly reach the muscle, and we can directly reach the central nervous system via nerve with electrical stimulation. And it's depending where the lesion is, how you apply electrical stimulation and what kind of parameters you choose. So, and here you see the little bits of differences in between. We are talking, and that's also a little bit about terminology if you read research articles. So electrical stimulation is all this, even more behind electrical stimulation. But in some articles you read neuromuscular stimulation, you read functional electrical stimulation, and you read direct muscle stimulation, or also long pulse stimulation. And behind those abbreviation, there is a meaning behind. And normally you talk about neuromuscular electrical stimulation when you are working on the level of strengthening, of reducing spasticity, and if you want to improve skin or bone quality. Only examples, it's not all, but to roughly understand. When we are talking about functional electrical stimulation, and that's given by name, you are talking about a function you want to restore, support, or to use the broad field of motor learning by applying electrical stimulation. When we go to the direct muscle or long pulse stimulation, then we are mostly talking about strengthening a muscle, also about motor learning, and that is quite new in the field of research about motor learning with direct muscle stimulation. We are talking the last 10 years. Before it was not a topic, and we can influence the structure of a muscle. So, and if we are on this side here, there has to be an upper motor neuron lesion. And on the other side, but with direct muscle stimulation, we have a lower motor neuron lesion. And if you use here these aspects with the parameter belonging to for a lower motor neuron lesion, you will have no effect. Vice versa, it's a little bit different, but the effect is reduced. So, and here we come in a logical continuation to the decision pathway when we are talking about electrical stimulation in patients with a neurological disease. So, as mentioned, we have an upper and a lower motor neuron lesion. And when we look to the targets and topics roughly, with an upper motor neuron lesion, we use stimulators that can create the parameter composition for nerve stimulation. And for instance, that is used with cycling, with rowing, but also with robotics. And there you can look to the, for instance, to an exoskeleton that is combined with electrical stimulation. And by looking to the stimulators, there's a possibility of the stimulation that is applied. We can use EMG triggered stimulation. That means that you have already some activity that can be produced and dedicated by EMG, and then the electrical stimulation is initiated by the voluntary activity in a muscle. We can have the cyclical electrical stimulation with the duty cycle I introduced you before. And of course, stimulators have switches that can be combined with those kinds of stimulation. And we have wireless systems, we have portable systems with and without wire. So there's a broad field, and you will see them later. And regarding the stimulation parameters, we are normally by an upper motor neuron lesion in between 250 to 400 microseconds, in between 20 and 50 hertz. And the stimulation is conducted either motorical or sensorily. Regardless of all those parameters and other aspects, it is quite crucial to define a goal and also to write down an expected outcome and then to evaluate if you can reach your expected outcome and the goal. And I highly recommend to do it from two perspectives. One is your perspective as the one applying the electrical stimulation, as a clinician, therapist, whoever. And the other perspective is the client's or the patient's perspective. And it's also important that it's written down, because only if you both match, you will have success. And so just a comment from me personally, the most important thing, what is the success of a treatment, what you think is success, is normally not the goal the patient has, because the patient wants to be somehow normal as he or she was before. And you see the progress in a rehabilitation, therefore match your expectations. Coming to the lower motor neuron lesion, so there are stimulators with long pulse stimulation, and they are quite rare. They are not so common. There are only a few, or very, to be honest, 2 on the market worldwide that really work. And the stimulation parameters are in between 200 and 35 milliseconds. And we are in a range of 0.86 to 22 hertz. You can create higher frequencies, but then the application is a little bit tricky in terms of skin burning or irritation of the skin. But if you are careful and use the right electrodes, that's quite fine. Even here, or especially here, the goal definition and the definition of the expected outcome and your evaluation is quite crucial. So now coming to different neurological diseases. And so here you see the different ones I put on the list, and I think that are the, in my point of view, the most common. We have the spinal cord injury, the stroke, the traumatic brain injuries, the multiple sclerosis, Parkinson's disease, Guillain-Barré syndrome, cerebral palsy, plexus lesions, all kinds of peripheral nerve injuries in the Charcot-Marie-Tooth disease. And we go quickly through what kind of lesion is behind, either an upper or lower motor neuron lesion. Now we go through. In spinal cord injury, we find two types of lesion. You can have an upper motor neuron lesion or a lower motor neuron lesion, depending where the lesion is. So as you all know, in spinal cord, so the spinal cord itself goes up to L1, and below L1 you are in the cauda equina, and the cauda equina belongs to the lower motor neuron, to the peripheral nerve system. Because there are no reflex arcs, you have not this, you have not the reflex arcs, the interneurons anymore. They are the cauda equina. And you have also, and then I come later when we are talking about diagnostics to it, you have also in tetraplegic patients on the level of lesion or in all kind of spinal cord injuries belonging to the central part from C0 to L1, you have on the level of lesion also a lower motor neuron lesion included, because there the anterior horn is due to the injury also damaged. So, but you will see it later. So that's a little bit tricky. We are here in I would say in a Twitter group. So here, stroke patients are very safe. They are very upper motor neuron lesioned. So that's quite more or less easy. The only aspect I have to mention, if you are with stroke patients, you are normally dealing with the elderly population, and by getting older, everybody, independent if you have a stroke or whatever, by getting older, you degenerate and you have an age-dependent degeneration, and so some parts of lower motor neuron lesions. That can be important when you are only working with strokes and you see sometimes difficulties by applying functional electrical stimulation via nerve. Traumatic brain injury are always upper motor neuron lesions. So then we are coming to MS. MS has also both. Normally, MS is an upper motor neuron lesion. But as you know, the plaques of MS can be somewhere in the central nervous system. And it occurs that these damages are in the spinal cord. And depending where they are in the spinal cord, then also the anterior horn cell might be affected. And if it's affected, then you can have on this level of innervation a lower motor neuron lesion. So that's the same with Parkinson's diseases. You can have both. It's not an LMMM, it's an LMN. So there's one letter missed. So then the Guillain-Barré syndrome might be an upper motor neuron lesion. Can be also the Guillain-Barré is normally expressed as a lower motor neuron lesion, and it's, to be honest, it's also both. It's depending where are the damages are. You have a lot of axonal damages, and then it's belonging to the upper motor neuron, even if it's a peripheral nerve disease. We have the CP. Oh, that's missing. That's an upper motor neuron lesion. I'm sorry. That has some. That's wrong. It's an upper motor neuron. Sorry for this. Peripheral nerve lesions, of course, are lower motor neuron lesions. The same with peripheral nerve injuries. You are belonging exactly to the lower motor neuron. And the Charcot-Marie-Tooth also is a lower motor, classical lower motor neuron lesion. And here, by looking to the system, but be aware, this is wrong with the CP, you know directly what kind of stimulation parameters you should use. In case of those who have both, please check it carefully in the region of stimulation. What are you dealing with? And then choose the parameters. So here you see in this slide the different forms of application, and in the center you see the names you already know, and I put one extra in, that's the transcutaneous spinal cord stimulation, since it is so well described in the media now that if it's implanted, that it can really regain function for walking. So, and I want to focus a little bit on it and give another perspective how far we are later on this research field. But at least I personally apply transcutaneous spinal cord stimulation for lower and upper extremities, also for supporting or improving function. Here you see all the different fields that you can work with. And as I said in the beginning, I want a little bit to dedicate on motor learning, because in clinics, that's the most used application of functional electrical stimulation. And I want a little bit also to focus on this breathing, because it's not so well known. And I think by looking to the composition of your group, it might be interesting for all of you to hear a little bit more about it. Of course, we will somehow touch also the others. And if you have questions regarding the other aspects, feel free to ask me. I could talk the entire day with you about all those fields. So this is a busy slide, but quite important again. And it's a little bit again repetition from what I said. And here you see all its green, it's upper motor neuron lesion. All the blue ones are lower motor neuron lesions. And the two-color ones are the ones who have or might have both kind of lesions. And here I added again some new aspects, the targets. So the target, we have this motor learning, strengthening that can be done, but reducing of spasticity in upper motor neuron lesions is a very common field by applying electrical stimulation, but in my point of view, a very challenging field to do it in a proper way that you really get your goal. You can treat contractures in both by applying electrical stimulation. And of course, this substitution of function, it's very well known by all those walking system and grasping systems. And the avoiding atrophy in both cases is quite important. And only mentioning one aspect is all the skin injuries or pressure sores in patients, and they are due to a lack of circulation and a lack of mass of muscles. And to build up muscles is quite successful and easy if you apply it properly with electrical stimulation. And so avoiding atrophy is one of a really good goal for patients, even without any function. If we look only to the lower motor neuron lesion with the field of all peripheral nerve injuries or the big group of polyneuropathy, then we see here the promoting peripheral nerve recovery. That's possible. There are quite good works already done. And at least you see the parameters again belonging to both kinds of lesions. Here again, here I added again the form of the stimulation, how you shape the electrical stimulation. And in upper motor neuron lesions, you see that you are dealing with a rectangular biphasic shape. And with lower motor neuron lesions, you have broad field. You can this triangular, rectangular, trapezoid form or shape this current. And that's somehow depending how the stimulation is accepted by the patient. And I have no idea if you ever tried electrical stimulation with with those parameters on yourself. And then you know that it might be quite not so nice, I would say. It's always depending how you explain it to a patient, but it's a form that can be very sensitive, disturbing. And by playing with the pulse shape, you can make it more comfortable. And so you have to choose what to do at least. So that's this. And you all heard, and especially those working in clinics, you heard about the ICF, the International Classification of Functioning, Disability and Health. And by working in clinics and applying for stimulators for home use, or by applying to get for somebody a stimulation system, you have to argue. And you have to argue in a proper way. And so the best accepted way to argue with insurances is to use an international classification. And so you have to know where you are. Are you in body structure and function, or are you dealing with activity participation? And here you see again those what are belonging to. The activity and participation part is coughing, self-care, grasping, walking, sport activities, standing or sitting. That's activity and participation. Without a proper sitting in a wheelchair, you can't participate in a normal or almost normal life. And if you look to body structure and function, then you are looking very purely to the function and the structure. That means reducing spasticity, breathing itself, strengthening, improving skin quality, improving bone quality, muscle structure, and improving the cardiovascular system to avoid secondary complication for people with neurological diseases. Good. And remember slide 12 we saw. Good. So in the application of electrical stimulation, there are two possibilities, I would say. You have the temporary application and the long-term application. And the temporary application is normally by applying neuromodulation, because neuromodulation is a topic you should apply very early after a neurological disease. There, the plasticity of the central nervous system is most sensitive. Then motor learning is also applied or performed during a very early stage, because there the improvement of function has the best success and outcome. But this I want to put into parentheses, because motor learning can be performed also in a later stage, in a chronic stage. And that's because of the silent motor units that you never stimulated in a proper way. So, but there, on this aspect, I want to focus later, but keep this a little bit in mind, but more or less it's a temporary application. Then strengthening. If you strengthen a muscle, then you do it in a training protocol and you never do it lifelong. And also treatment of contractures should be done in a temporary application. If you reach your goal, you can stop it. So if you are going to long-term, in contrast to this, in long-term application, if electrical stimulation is used as support of a function, and the best example is all the gait systems. You can use gait systems with electrical stimulation instead of an ankle-foot orthosis. And then the stimulation system is the ankle-foot orthosis, the electrical one. And therefore, you need it lifelong. You can use it the entire day to walk. All the prevention aspects, and I'm talking about subluxation of the shoulder joint in high tetraplegics. If you have a complete C3 lesion, then you have to do your prevention for subluxation of the shoulder lifelong to avoid shoulder pain and contractures, if it's important for the individual case. But that's not a temporary application. If you have pain due to immobilization because you're sitting the whole day in a wheelchair all your life, then it's a long-term application. And I have some patients doing some cycling with arms or legs because they feel they have the sensory pathways in the central nervous system working quite good, but motorically they are completely paralyzed. That are the typical spinal cord patients, Asia, the AIS classification B. They can't move anything but feel quite properly. And the cardiovascular health in a stable neurological stimulation supported by FES application is also a long-term application. And so that is mostly the cycling if you do it for prevention of secondary complication as getting stroke or some other issues in case of a spinal cord injury, and in case of also of a stroke, not to get again a stroke. So that's the long-term application you have to perform. If you want to combine all those things with the usage of robotics, then there are, of course, we can divide into lower limbs and upper limbs. And if we go first the lower limb pathway. If we are looking to the lower limbs, we have those stationary devices, and you can have them without and with electrical stimulation, but we are talking today with electrical stimulation, so we are focusing on those with. And so you have mobile devices, all the exoskeletons, and they can be used with and without electrical stimulation. And if you go then, we have the Locomat, the gait trainer Geo, the elliptical training, and all that I've not mentioned now. So there are a lot of it. And I only want to mention, yes, there are a lot, for instance, the Locomat, and the Locomat is not performed with electrical stimulation, but you can easily perform it with electrical stimulation with walking systems independently that are that perform the stimulation that is angle dependent or by foot switches or however. So it can be combined even if the device has itself not the pre-programmed or synchronized possibility to do so. Then you have the mobile devices. The all kinds of exoskeletons. You have the exobionics, the most popular, and the rework. And the exobionics has now the possibility, or has since some years, the possibility to do it with electrical stimulation, and it's performed with the Hazomate stimulator. You have the rework system that is not available with electrical stimulation, but even this, as I mentioned before, you can combine it if you have other devices. Then for the upper limbs, there are also the differentiation between stationary devices and mobile devices. And here there are only a few possible with electrical stimulation. And so there's the most common ones are those from Hokoma, the Ameo Power Spring and all those, but there are other systems that I mentioned here. So the market is quite open and a lot of things are there. And I'm fascinated because I love robotics, but you have to be very careful to choose the right one for your patient group. And then you have also here mobile devices. They are not very common in clinics because the feasibility of the application is not, I would say, made for clinical use because it takes by far too long. If somebody of you have other experience, I would be glad to share your experience with mine. But at least they are existing, and technological development never stops. So I'm sure that we will find in a few years appropriate stimulation devices on the market that also are feasible in usage for clinicians. And of course, you combine everything with virtual reality. And imagine what kind of impact you can get into a central nervous system if you do the virtual reality input, if you do the movement and support the movement with electrical stimulation to reach all the cortical spinal tract that is possible to reach. So you have the maximum input, and we can really talk about neuromodulation or plasticity, modifying plasticity in these cases, if you combine it in a proper way. So to getting a little bit from the theoretical part into the practical part, I give you an example of a patient. And the photos are not only from one patient, but just to give you the idea how it could be set up. And I want to set up it by giving you an example of a tetraplegic patient, level cervical 3, Asia impairment scale C in acute phase. So for all of you not familiar with the Asia classification, AISC, the Asia impairment scale 3, means that the most important muscles under the level of C3, segmentally innervated, have 50% of them have at least a 3 from a manual muscle test. That means they are able to activate those muscles against gravity, not against resistance, against gravity. So that is this. So this person with an Asia impairment scale C has function. It's possible to move voluntarily, not against gravity, but however able to do a lot. So, and if you decide to apply FES or not, that's decision way of each individual clinic, able to combine it with FES or not. You can use systems where you can combine it for instance, the motion maker, and you see the picture here. This is a robotic device where you can apply electrical stimulation with leg movements, and the leg movements are performed in a concentric and eccentric muscle contraction. You can do cycling, or you can do leg press movements. And here in this device, in this orthosis of this robotic device, you have position sensors in the hip, knee, and ankle. And under the foot plate, you have force sensors. And this device is able to calculate the movement in terms of distance and time, and applies, according the distance and time that is used, the amount of electrical stimulation that is needed in this phase of the movement. So, and if a movement has to be eccentric, this device is also able to mimic the eccentric muscle contraction. That means it applies stimulation by when the patient is slowly releasing or relaxing the muscle activity. So both possibilities are doable with this device. Of course, this eccentric one is a mimic of eccentric. It's not real eccentric in a physiological way. So then you have the exoskeletons, all forms of, and depending on what kind of phase in the rehabilitation you are, you use whatever you want. And during this process, I highly recommend also to look if other parts of the body should be trained. Because if you look to the C3 tetraplegic person, there are also a lot of issues with the arms, upper limbs, and with the trunk. And even if the legs are quite well, the trunk, you need a trunk to walk properly. So walking only with legs is not effective, and you can't perform it. So very often exercises in the trunk and in the upper limbs are needed to walk again, at least over ground, because also over ground means that probably you need some crutches or support for your arms. And if your arms as a tetraplegic patient are not properly trained and stable, then you get problems in the shoulder, and that is something you should avoid. So you see, it's a very complex structure, but it's fascinating, and I would say decided for every individual. And you have some patterns you see in similar lesions, but I'm working since more than 30 years with spinal cords now together, and I can tell you, you rarely find exactly the same lesion, even if it's written on the schedule that's the same lesion, or tested as same lesion. Coming to the technical equipment I'm using. So for me, names are nothing, but I want to give you an example just to show you with what I'm working. I will never say that there are other devices on the market that are not better or easier to use, and it's a little bit depend where you are living, what is supported, and especially now in the days of the medical device regulation, you have to look which device you can use in your country to get the approval for it. So, and I'm in Switzerland, I'm a little bit in a zone of a desert there, and I had to talk with all the companies to have a general support in Switzerland to bring in the devices again after this disaster, when Switzerland decided to quit the contract with the rest from Europe. So, however, we are using the motion maker, the Omego, that's from Trio Motion device, the Berkel bike, you know it from the Cybertron probably, the RT300, that is quite popular and common used in Italy. We have stationary cycling and cranking devices with FES in combination. We have EMG triggered stimulators, and I prefer the old and the new Stivell Pro. It's a quite good device to program and to do a lot of things. The Intento is also a good device. We have all kind of gait devices, and I will focus on gait later. We have grasp systems for the upper limbs, and for the breathing we have the Raise Power, and you will see what it is, and they are all for upper motor neuron lesions. All what I'm mentioning here, you can't use it for lower motor neuron lesion. The Stivell Pro, yes, but not with EMG triggered, so be aware of this. And for lower motor neuron lesion, we have some stimulators with 8, 4, and 2 channels, but with low capacity, only for very small muscle groups. And if you want to do really good long pulse stimulation, then you have to use the RISE stimulator. That's worldwide the only one that is effective. And that's from an enterprise in Austria. And you can't, it's useless to deal with other devices because they don't give you, unfortunately, the power for bigger muscles. Good. How does it look like? I'm talking about robotics, virtual reality, electrical stimulation. And it's so that sometimes you think, how will you put it into clinics? So I know I get a lot of comments that's not possible to apply it in treatment. And I can tell you it is possible to apply it in treatment. I do it on a regular basis every day. That's what we are doing in the FES Center. And you see it here. We have the virtual reality. And here in this case, we are combining it for hand function in a person that has a lower motor neuron lesion in the intrinsic muscles of the right hand. And this is the stimulator. I was talking about the RISE stimulator. And here in the background, you see what he is doing, what he is performing. We use always the screen in the background because we want to see. In this example, that's a colleague. We tested the system here. She is using it with electrical stimulation for the wrist of her left arm or left hand. And we are combining it, and we try to find a synchronization self-programmed with the activity that is used. And here we tested again some devices or some features from virtual reality, and we tested it here for posture. And that's quite interesting. And that's not something that has to do with electrical stimulation now. But if you want to catch a butterfly on your hand and you get this goal, you're automatically being straight. You extend your spine, because if you want to catch this butterfly, it's not a heavy, it's a very fine, low-weighted object, a butterfly, and you try to catch it carefully. And that makes, and if you imagine yourself this movement, if you want to catch a butterfly and you are sitting in a complete flexed position, then you would never do this. You would do, oh, where's the butterfly? And we try to figure out, and later we combined it with electrical stimulation. So you need a little bit time for the setting, but if you have it at your place and you can use it directly, it's doable to perform it. And I will show you a short video just by all the talking to get your mind a little bit refreshed, what we do. And it's a little bit how you can do it with cycling. Here you see the person with a setup of the cycling, and the cycling setup is on the tip end, the gastrocs, the quads, the ischius, and the hamstrings, and the glutes and hamstrings correctly. And we once did it with the motor-made device, and here you can see the same setup with the Berkel bike by using the arms voluntarily, and that's quite interesting. You can do amazing things by applying it on a screen and combining it in a real life setting. And we use the Berkel bike because you can do it quite easily outside and inside. Outside, you need not the virtual reality. So now we are coming to our first interaction, because I talked now, more than an hour. That's time for the first interaction. So I want to share some ideas and to warm you up. It's always difficult to talk about something. So also, despite you have questions. And I have some questions prepared to think about. And please think about, do I respect the patient's physical and mental resources by applying technology, especially electrical stimulation? What's my own and the team knowledge about the stimulators? Do we have the capacity to modify the stimulation set for each individual? Are we willing to do this? And what do you think about the intuitive treatment? What you think should be done, and the evidence-based treatment? And therefore, I want to open a short discussion with you. So I do this, that I can see you and the one who wants to say something. Please, I'm listening. Comments. I shake you being awake again after my long talk, 1 hour talk. Now I want to talk with you all.
May I ask a question?
Wait, I stop the presentation of my screen, because then I see you. Yeah, perfect.
Okay. My question is about critical
Wait,
illness.
before I'm talking, I don't see, I'm not, but Martino, it's you, right?
Yes.
Okay,
Yeah.
I've seen you. Okay, Martino, now.
Okay. I work with critical ill patients in
Critical illness.
intensive care. So you talk about coughing. So how do you manage coughing with electrical stimulation? Because usually we use coughing assist machines or devices or other
So I will
techniques.
introduce, very good question. Yeah, we are also using the cough assist. So that's nothing that you should not use anymore. That's not, can't be replaced by electrical stimulation, not at all. That's a really brilliant device. I use, in addition, for weaning and for supporting the function, you will really see it later in detail, I use the raise power, and this device giving you previously the answer, it's applying in the inspiration the phrenic nerve stimulation directly to the diaphragm, and in the expiration phase, the abdominal wall as a forced expiration. If you want to do coughing, then I apply directly on the abdominal wall to give stability there. And I do it with systems with switches to press in the moment they want to cough. If you are working with critical illness patients, you have to test them before, because critical illness patients have a lot of de-innervation, so lower motor neuron lesion. And if you are talking with lower motor neuron lesion, you are quite limited by applying electrical stimulation, to be honest. So if you can stimulate via nerve the abdominal wall, that's perfect. If not, you can skip it for coughing. If you can, and in critical illnesses has to be tested, stimulate via nerve, the phrenic nerve, then it's perfect. Then you can stimulate directly the phrenic nerve in the inspiration, and then you can combine it with manual support.
Using a transesophageal catheter?
No, we are not using it. I'm applying it directly here in this region where you get direct access with surface electrode to the small ones, to the phrenic nerve. We don't do it because, but that's a philosophy of a hospital. And so, because if you use a catheter, we did it once, you get a lot of irritation for swallowing, and also you get a stimulus for the sympathetic and vagus system, and you create even more secretion with it. So it's a stimulus to having at least the salvation is a little bit more, and that might be critical, and therefore we don't use it. But that's a philosophy of the clinic, what they think about the airway management. I can only tell you the reasons why we don't do it. And I've done it once in a patient because I wanted to try the system. I thought it is quite interesting, the system. And he had a lot of difficulties. He could cough in a proper way and we could do a good management, but he could not swallow anymore. And so he had to get back to his pack for nutrition on the stomach. So it was like, and we decided to do it on a surface way and it works quite good. So is it answering your question?
Yeah, quite a bit. And I have another question.
Yeah,
One challenging thing in these patients is that we have to start exercise as soon as possible. So one of the most common devices is the Motomed. It's a sort of cycle
I
that you
know the
can put
model.
over the bed. Okay. Is it useful to apply neuromuscular stimulation combined with Motomed? Because the voluntary contraction can't be detected just using Motomed, just cycling. So to maximize the effect, do you ever try to combine both?
Yes. So in intensive care, we use the Motomed Leto. You know this device, perhaps? Okay. So so I'm coming back to your critical illness population. I would test them if you see a muscle contraction, not voluntary. Let's only talk about muscle contraction elicited via nerve. And if you don't see one, then you can be sure that the electrical stimulation in terms of growing muscle mass or getting better activity will not be successful. But if you are talking about the sensory input for the sensory nerves, just to get the idea what kind of movement is belonging to what kind of muscle activation, sensory, only sensory, then you can argue, I want to stimulate the sensory part and apply it even if I see no contraction by performing. But then I would recommend only to do sensory stimulation. That means that you are below an expected muscle threshold, that you are only stimulating the C nerve fibers and not other ones, only those that are responsible. And that means that you apply, for instance, on a quadriceps, that you are in a range of in between 20 and 30 milliamps. Normally, you would see a contraction from 30 up in us, if we are, so you know, okay, that's not possible in this case. We will never see, even if you increase up to 100, you get only a lot of current in, but no reaction. So then you reduce and deal with these sensory fibers and stay below. Then it might be very effective. But don't tell anybody that you will strengthen the muscle. That will not be true. That's so the target, you know, what do you expect? Yeah. Okay.
One last question.
Yeah, go on.
Those patients, there is sometimes a difficult to understand if they can contract or not, because there is also a myopathy. and maybe medicaments that change the central drive. I mean, okay, they're not always awake. That's it.
Yeah.
So it is possible to use electrical stimulation to elicit a contraction and somehow understand the muscle is okay or not.
So if you want, so the muscle mostly is okay. So I can tell you the muscle mostly is okay. So if you want to see if the muscle is not degenerated to amounts that it is difficult from a structural level, then maybe are talking about lower motor neuron lesions, then you have to apply long pulse stimulation directly onto your target muscle to test it. Or you apply nerve stimulation, and I will go to later on the diagnostic part, Martina, on it, to see if you have a de-innervation or not. And if you have a de-innervation, then you can check your own hypothesis by applying direct muscle stimulation. And if you are not over 10 years in a very chronic stage, then you will get a response for single twitches in direct muscle stimulation. Then you can test it, yes. And if you want to rebuild a muscle, then you have to use in these lower motor neuron lesion affected muscles long pulse stimulation. You will never get a response or success for muscle change structure with nerve stimulations. That's not possible. That's physiological, does not work. Mm-hmm. Is this clear for you?
Yeah.
Yeah, you can tell me, no, I didn't understand, you are too complicated in your words. Please tell me that's very important for me.
It's quite my question was about because when you are in critical care, the first goal is to step down. So a way to recognize immediately what can be the challenge in rehabilitation after the step down it is very interesting.
Yeah,
because you
of
can
course.
give
So my personal opinion in this is I'm not caring about, in this case, when I want to initiate the metabolic factor in a person. I never would care about it's a lower or upper motor neuron lesion. I would get some metabolic input in. And I think for this, if you start not by training 1 hour, by starting very smoothly the training, I would apply electrical stimulation in the big muscle groups, because in the big muscle groups, there you can increase the metabolic factors. So I would apply even if I would not see a contraction in it. That would be the optimal way. And so a colleague of mine, Get Elan, I don't know if you came across by reading some literature, he did with critical illness patients. He did some research, but only cases. And he could even see by applying electrical stimulation on the big muscle groups without any movement, that there was an effect on the circulation by not having. So that means if you would put them electrodes on the quadriceps, on the glutes, on the hamstrings, and so I would also include the calf muscles. So because they are quite crucial for this. So and if you stimulate them in lying position, or if you can verticalize them in a standing bed, give some load on it, then it would be also very good. You know, you can always deal with the Rolls-Royce, with the normal car, or with a small car, and you would have a very good Mercedes if you do this with a load. So therefore, I would go for it, yes. If you have the possibility, I can recommend it from my perspective. Mm-hmm. And do some research with this if you have the possibility, Martino. I would be very fascinated to read about it.
I would like to do some research, but it's very hard.
Yeah, I know. Where are you working, Martino?
I work in a Hospital in Lecco, Merate.
Yeah, okay. But even if you can, if somebody give you the time and a little money that you can do 3 to 5 cases, I can encourage you, because there is so less published. It would be for clinicians. It's not so scientific evidence is perfect, but clinical evidence is also very important. And even if you are not statistically significant with your results, if you are clinical significant, it's perfect. It's worth to do so. I only want to motivate you.
Okay, one burden is the cost of the stimulators, because they are not so cheap.
No, but get in contact with the companies and ask them to give you a device only for the period of the experiment. It's worth to ask them that you want, and you can reduce the costs by not buying it. Only if you have the energy, go for it. And it would be a perfect master thesis, by the way, if you have no. And I would support you if you want.
Thank you a lot.
Good. Other ideas, what I mentioned on the list, questions, feel free to comment.
Ines, I'm Eleonora, I'm a physical therapist at Bosisio Parini, la nostra famiglia.
Mm-hmm.
I have a first question on the use of electrical stimulation for prevention of contractures, as you said
Mm-hmm.
before.
Mm-hmm.
I mean, I don't use electrical stimulation in my common practice, so I'm not so I don't know so much in this field, but I imagine when I deal with the contractions, probably you apply electrical stimulation on antagonist muscles or not. You do electrical stimulation on agonist, even if you want to prevent contractures?
I do it on both, and I do it in a alternating way. So I program the stimulators that once the agonists are activated, and then the antagonists. So, and you can see really the slight movement. It's a little bit tricky to adjust the intensity that you do not get an overspill on other active muscles and get a worse position. But if you do it in a very, you can set it up. For instance, if we have contractures, let's talk about the hand, because it's easy to show. I not lift my leg up here. So then you stimulate, if you have contractures in the flexors of the fingers, then you apply the electrical stimulation of the extensor digitorum communis and put small electrodes on and activate them, and for about 10 seconds. And then that's a pause for the stimulation. And at the same time, the flexes start to be activated. Then you activate again the flexes and then the extensors. And you can do it in a timely, non-equal way. That means you activate a little bit longer the extensors and a shorter way the flexes. Okay. That's quite good if they are both have both an upper motor neuron lesion. That's perfect to do so, and it's very successful. We have only one exception if you deal already with capsular contractures or joint contractures. If you are in this stage, joint contractures, you can try it, but the outcome is, it's poor.
Okay.
That has to be tested in what kind of contracture. So if you deal really with muscle contractures and beginning capsular contractures, then you can Over time, you need time, and you have to apply this kind of stimulation 3 times for about 20 minutes a day. So very often, short time, but very often.
Mhm.
And but if you have already joint contractures, no.
Okay.
I would say
Thank you.
no successful.
Okay,
So,
thank you. And another question.
yeah.
I deal with DMD patient, the muscle dystrophy,
Yes.
DMD, Becker, and so on. You didn't talk about this kind of patient, but what do you think about electrical stimulation in this field? There's a very poor, the literature is really poor. There are different kind of way of thinking about this topic.
Yeah, me too. So I mean, so it was very, yeah. It was. I know that I didn't put it on, and it has one reason, because to be honest, I can't give you a scientific answer. In my outpatient service, we have actually 7 muscle dystrophies coming to the FES center to be treated with electrical stimulation. And I was really afraid of starting with them because the literature is poor, more than poor. And then I went to all the literature, and that's what I normally do, all the principles of electrical stimulation, regardless what kind of disease I have. And at least I figured out, okay, I can work, why in some cases, so muscle dystrophies are so various. In some types, I can work with nerve stimulation, and I can try to feed the central nervous system that I can a little bit slow down the progression of the disease, or that I can give some metabolic input into the muscle that over the day or over several hours, the muscles can be used better.
Okay.
So wait, just,
okay.
but the only thing is you have to avoid fatigue. And this has to be tested individual with each patient. So all of our patients coming to us report, and we are collecting the data, report that they can move over time better, but they don't have an increased mobility or force, but they can keep it over the day in a good way, being less fatigue. So
yeah, I mean so you deal on the nerve stimulation and not on a muscle stimulation, and this your approach is near all. I don't know. Just a moment. In English, it's not so simple for me.
say it in Italy. Perhaps we can communicate
Okay.
shortly in Italy.
Ci provo, ok, perché molta letteratura sull'argomento che valuta non un approccio di elettrostimolazione, ma un approccio di trattamento fisioterapico riabilitativo, infatti sostiene che l'allenamento nel paziente neuromuscolare non è tanto, cioè non arriva tanto a modificare quello che è l'approccio del muscolo. Sì, ok, lavori sull'atrofia da non uso o altro, ma nel momento in cui il muscolo è arrivato al suo culmine, probabilmente lavori su quelli che sono gli aspetti del nervo legati a come il nervo va a stimolare le fibre che rimangono, e quindi fitta con quello che stai dicendo adesso rispetto ad andare a stimolare la parte nervosa.
Esattamente. Okay. Now I continue. I respond to you in English.
Okay.
So you're absolutely right. If you are to apply nerve stimulation, you are only deal with the nerves and with no parts of degeneration. We have 3 cases in which in who we do both. So they do nerve stimulation for 15 minutes. They do it in a domestic setting, and for 30 minutes, they do direct muscle stimulation, long pulse stimulation. And our assessment to see if we can somehow keeps the situation or change the situation on a structural base, we do it with ultrasound. And you can see in ultrasound the target muscle. If it's degenerated, you see this white connective tissue and fat, and you see the loss of pennation angles in the muscle. And then we apply the stimulation, and we have a look if we can decrease the connective tissue and see somehow new pennation angles coming up. And up to date, I have to be honest, we see that you see a little bit less wide structure, but no pennation angle in muscular diseases. In muscle dystrophies. So,
Dystrophy, yeah.
Yeah, that's what I can up to date, but we will follow it. And so I know it from degenerated muscles that if you want to change already connective tissue or decrease connective tissue and create muscle tissue, that's possible. But depending on the length of a lower motor neuron lesion and the amount of connective tissue and fat tissue in a muscle, it takes years. So now you can argue, is it worth to do or not? In some cases, I would say yes. In some cases, I would say, okay, if there's a lifetime limitation, then I always say, perhaps it's better to live and to do other things that are really have the value and not to waste time where we not really know up to date.
Yeah.
So it's, so my clinical heart is a little bit, I talk to the individual. And if you are talking to muscle dystrophies, Duchenne in children, I would say, give them the time they have.
Yeah, I totally agree with you. Yeah.
So it's my ethical, but that's
Yeah.
my personal ethical approach to it. So
Totally agree. Okay.
so does this answer your question?
Yeah. Yeah.
Okay.
Thank you.
You're welcome. Other comments and questions?
Yes, maybe me. Good morning.
Yeah,
I'm
Silvia.
Silvia Campagnini. I work in Dognocchi in Florence, and I'm an engineer. I work in a unit which is using artificial intelligence on clinical data. Usually the applications we have are mainly for prognosis and diagnosis with the idea to, personalize and optimize the rehabilitation treatment. So when you mentioned personalization among the questions, I thought, do you have some experience on the application of artificial intelligence on your field for these purposes? And does it make sense or?
So I have ideas, but not personal experience. So I would, but I think I talked also to an engineer in Canada, and he asked me somehow a little bit the same question. And I think there's room to using artificial intelligence for personalizing or for an individual where you can apply personalized and artificial intelligence in an environment where you can, make life, I would say, make life easier if you are not possible to move yourself. And I would say yes, but I give you an example. We have so many high tetraplegic patients, and so they are lying in their, so in Switzerland, we try to send them home or in a setting where they can live more or less not independent, but also a little bit an individual life. So if you have a patient completely dependent from a respirator, it would be nice if they can stay in a room by their own and can start their day by having the window open, the first stimulation of the breathing system going on. And if you see that the stimulation is decreasing, then getting the next decreasing in amount, getting the next parameter onto it, so that you can individualize for somebody who's completely independent, to be a little bit alone and not always such people around making some work, because those people want to have their privacy. And I could imagine, that's only a little example, but you could set up an environment for them, not being independent, but getting them a little bit more privacy. Or if they are having a walk around the house, and if they have the wish to do it alone, why not? We all have the wish to be sometimes not only having a shadow in behind. So yes, I see there are technical possibilities by using artificial intelligence to make this possible for individuals. Yes, I would say yes.
Thank you.
Okay. Other questions?
One more, I'm sorry, I'm too curious. Martino.
Yeah, I
Yeah.
see you. Mhm.
Okay, in a rehabilitation clinic, we try to use virtual reality combined with exercise therapy, no? What is your opinion in adding virtual reality into cycling, in example? So in the slides, so
I would do it, and I would not only do cycling and virtual reality, I would put extra electrodes on. Yes, I would go for it. The only thing that's my main criticism in virtual reality features. There are a lot of them are not related to the background of the patient. They are not patient focused. If I give you an example, if I have an elderly woman, she's used to plant their plants in the garden. And then I do virtual reality features with her by shooting some animals or by throwing a ball. Then I have my doubts if this has the right input. You know, I had a colleague, she was with those kind of women, she was using a ball game, and she wear glasses, and she was completely horrified by having a ball coming in front of her face because of her glasses. She was not so young anymore, but she wanted to knit. She wanted to sew because she did it professionally. And I think we should be able to create virtual reality then related to the focus on the patient. And then I think it's completely perfect. If you could do planting or sewing or knitting with those people, and it's not so difficult to perform. You have an iPhone and you probably find people knitting. So make a short video when they knit and give it to the on a head system and put your iPhone in with your video made. We did a lot of such simple things. And I think, I personally, if you believe in motor learning and relearning and the strategy that you should refocus on already learned skills, that you have the best impact. If you believe in this, what literature says, then we have to modify our virtual reality games regarding the goals of the patient. That's my opinion, if you bring research together.
In our trial, it wasn't so effective. The real effectiveness was given by the volume training. That's it.
Okay. Oh, yeah, so you're touching another topic, the volume of the training. Yes, we are by far too low in our volume in rehabilitation. Yeah, I totally agree. But that's another aspect. I would not put it in relation that the other was not effective. I think neither virtual reality, neither electrical stimulation, neither our normal physio, occupational, or whatever therapy will be effective if we don't have the right volume. Because we can't relearn with only 20 minutes a day. And the rest, we get no input in the right direction. We have to, so well, the volume is something apart, especially in neuromodulation and motor learning. Yeah. Completely.
One feature that was not expected is that some patients say that they prefer a class group, a group of people, because they can interact. So it was more fun for them. So compared to standard, it was better standard. That's
Yes, it's, I believe this completely. So by background, I'm also a teacher. I did a teacher education years ago. And you have different learning types. That's another aspect. And there's a very good work by Wolf. I have this literature in the presentation. And she shows that different learning types need different approaches. So I completely believe that some people can learn better in a group by interacting. That's another aspect we should, So we are dealing in motor learning or bringing the central nervous system to work again with so many aspects that should fit together. And we are mostly touching only one or two. And that does not mean that this method would not be effective, but others are missing. So, and to find the optimal for each individual, that's really a challenge. And therefore, the tendency to generalize treatment is really something that will not bring us the effect of rehabilitation, I think. But you are complete. I completely agree with you what you are talking about.
Thanks a lot.
Are there comments or aspects?
Sorry, Ines, another quick question. But
yes.
do you I'm always Eleonora.
Yeah, I see you. Yeah, Eleonora.
Do you
now
use,
I know your voice, both. So
okay.
now
Okay. Do you use virtual reality also in lower motor neuron lesions?
Yes, I do.
Because I in my mind there's the extra game with virtual reality could be really engaging, more engaging than doing a simple exercise. But what's the rationale, the background for using it also in lower motor neuron lesions?
There is new research from Zenger and also from Jonathan Jarvis. I'm talking a lot with him. He is dedicating on a lot of lower motor neuron lesions. If you stimulate the muscle, and I'm not talking about chronic ones, I'm talking about acute, subacute ones. If you're stimulating the muscle and you give the contraction, you have also an input on the end plate of the muscle and on the nerve. And if you are stimulating the muscle and getting virtual reality features, then you use a cortical input. Then you might have an effect of reinnervation of this muscle. So that's the combination of getting the muscle contracted, having a stimulus to the end plate, and on the other hand, you give from using virtual reality onto the motor cortex, the input that is traveling through the spinal cord to the target muscle that can give a positive effect on reinnervation in those patients.
I was thinking about another kind of patient that I follow is Charcot-Marie-Tooth,
Yeah.
and it could be useful also in this case. So okay.
Yeah, I have one perfect example, but only one because he is so motivated to continue. So and it was quite interesting, he started with direct muscle stimulation, and he was participant of a study I did in the upper limbs. And then he asked me to do it also in the feet, because it was successful in the hand. We could convert already changed fatty tissue into contractile muscle tissue. And by having these changes, the elasticity of this muscle was better, and the neighboring muscles' voluntary functioning could work in a better way, because the tension direction of the affected muscle was different because of different elasticity. And so he could use his hands better. It was an indirect improvement of function. And so then he started the same in the legs or in the foot, because the foot were, and we could convert the tibialis anterior a little, and so decrease the activity, the voluntary activity of the tibialis posterior, and he was more stable in walking. So yeah, it makes concrete
Okay.
example, it makes sense.
Okay.
But
And
it's a long-term application, huh? If you stop, then you lose it.
Yeah. Probably all lifespan. Yeah. And probably you agree also to do this kind of electrical stimulation after surgery or after, so in an acute phase, even in this kind of population.
Yes, I recommend.
Okay.
And especially if you do somehow nerve transfers, I would do it, and I'm doing it. So to be honest, so that's one of my really, especially in the upper limbs, I always recommend to do both muscle and nerve stimulation. And I do muscle stimulation after 14 days. I start after a nerve graft. And I'm working together with the hand surgeon for peripheral nerve injury in Lucerne, and they sent me a lot of patients, and it works quite good. And we apply nerve stimulation directly, because you are on a level where you receive only the C fibers, and it's completely fine and not dangerous.
Okay.
But you have to work with those people close together to convince them to show what you are doing, and also to check in ultrasounds that you really do not get in contraction. Yeah, because that's quite dangerous after nerve surgery.
Thank you.
Okay, I would say I proceed. I share my screen. So Silvia is agreeing. Now we talked some. No, I have to do this, and I will be here again. Okay. So do you see everything? Yes.
Yes.
Okay, perfect. So we go on. We go on to new modulation before we come to a break, but we have to speed up a little. So new modulation. So and I give you the most used definition. Is defined as an intervention with a central or peripheral nervous system that alters electrically or chemically activities to improve physical function. And if you are looking back to the theory how electrical stimulation works, then we are on an electrical and on a chemical level. So that means we can use electrical stimulation somehow for new modulation. And so if we look to this slide, and I was a little bit always touching those points, we have different modalities. We have the sensory stimulation, only efferent. We have the motorical, only efferent stimulation. And once we are below the motor threshold and above the motor threshold, and we have also the transcutaneous spinal cord stimulation, where we go via the dorsal roots. And those modalities we have, and if we look, all those have the idea to retrain the nervous system and for form that reconstructs residual functions and promote new neural connectivity. So those can be initiated or a little bit, or not a little bit, supported by electrical stimulation. So this background we have. And keep these modalities in mind when I come back to the practical parts. So, and here you see neuromodulation, how it might be implemented into clinics. And you're coming from different parts. And as Martino mentioned, he's working in a smaller unit. So it's difficult to bring everything together. And so all those points we want to do with neuromodulation, with robotic and electrical stimulation, has to be combined with all the other skills we have to bring in a rehabilitation process to make our client as best rehabilitated as possible and independent. So, but one thing we have to do is repetitive task-specific movements, and the volume, as Martino also said, of the day, twice, better twice, but at least once a day, patients should be treated over time. Not easy sometimes, I know. So going back to the neuromodulators in the treatment. So we are dealing with neural circuits, and they are use dependent, and the plasticity is use dependent. That means it's very easy, and we all know it, that are so easy words, we read it everywhere, but we have to transfer it into clinic. So that means a decreased low usage results in a reuse capacity, and higher usage, increased usage is associated with improved efficiency of these circuits. So that means you need to apply a certain input on the system to be effective in your skill you want to train. And 20 minutes a day is really a drop on a hot stone. So, and here again, that's also for you to have this in a written form. So these repetitive activities, they promote the plasticity, and motor control depends on descending supraspinal drive. And we know, and that's interesting, that those supraspinal circuits and the motor units, they are responsible for hand function. And you can, that are the most direct in the central nervous system. So if you train here in a good way, then it's really effective for the upper limbs, also for stroke patients. That's quite crucial. So a reduction in this cortical excitability means also a maladaptive cortical plasticity, and this reduces again the supraspinal drive. This is in the descending pathway. So that we know. And so we know also in case of spinal cords that the brain gets less information because of the interruption here. And that means also that there's less drive to the below the level of lesion, and those tracts and the ascending and descending tracts continue to deteriorate. And that's a very old theory from the 1950s. And you know all this Hebbian theory, neurons that fire together, wire together. And on this base, if you go into the literature, then you see that FES has good evidence to strengthen the functional pathways, to guide adaptive plasticity, to activate the damaged network, and to induce neural plasticity via cortical controlled FES. And that might be perhaps in the future cortical controlled FES combined with artificial intelligence. I see also here capacity to develop something. Good. Future perspectives, and that's what I experienced with a group now in Finland. I will dedicate, and I think that's quite a fascinating way also to work, is the paired associative stimulation, where you get via the motor cortex, you detect the hotspots for the periphery of nerves, and that might be in the hand, the radial, median, ulnar nerve. It might be also the nerves in the legs. So it's both possible depending where you detect, but with transcutaneous magnetic stimulation, the hotspot for the target region, and you give at the same time a stimulus via motor cortex, and the detected nerve in the periphery, and you stimulate there, and you get the connection where both ways will meet, and you get, of course, a really good outcome in the upper and lower limbs. It's not a method already applied in clinics. It's on in the level of research, and it's in the phase of getting to be approved for a clinical treatment. Yes, the only thing is in lower motor neuron lesion, it works less because you need an intact lower motor neuron for this application. So there will be limitation, but I worked with this for 10 days this summer, and it's quite amazing that you get really good improvement and long-lasting improvement. So I want to focus on motor learning. You know, motor learning comes from your development in the first 2 years of your life. And so how can we put motor learning into this process? And we have this rule of 5. So that means start in a timely manner after injury. Patients should be in an active participation, and you avoid applying electrical stimulation. However, separately, I see it very often. They do therapy, and afterwards we do some stimulation apart. Please combine it. So the movement should be performed as functional as possible. You can combine it with conventional rehabilitation modalities easily. So, and 1 hour per day would be nice. So in case of spinal cords, yes, in the initial phase of the spinal shock, you will be less effective and you have only minimal response. So that must be built up over time. So then there is a partial similarity. That means at least that the intention of doing a movement and the triggered stimulation you want to combine should be in a very short time delay. That means if you trigger stimulation and you will conduct the movement, it should be in about time delay of 80 to 160 milliseconds. So you have not a lot of time to induce a movement. And all the engineers would be delighted now listening to me. Please construct stimulation systems would be perfect, where you can detect the desire of a movement from the motor cortex, and at the same time you send the stimulus to the target muscle. Perfect, I would say. And how does it look like in my simple way? I do it in clinical practice. You see a girl with a cerebral palsy and she can't open her hand, and I'm using a system from Spain. That's a fascia grasp system I'm using. And you hear my voice. I can make me silent here. So, and she is catching the ball and her right arm is stimulated when the ball is coming, and I've tried to do it synchronously with when the ball is coming, when she should open her hand and she throws the ball back. It's the same only by doing this, you see. And so she has this external focus and has also fun by doing this. Just to let you know how it can be transferred into clinics, sorry. And here you see it combined with virtual reality, and this patient is giving his stimulus at the same time by doing the movement. And he's catching things on the screen. He sees what he should catch, and so he does, and giving at the same time his own stimulation when he wants to perform the movement. Here it's in practice, and you see I'm using sponges here, and by using sponges that means that we have direct muscle stimulation, and I combine it with moving, with pushing up activities. It's more simple, but you can apply it during the therapy. Just another more fancy example. He's a Guillain-Barré patient, and he was a boulderer before, that means for over years. And he is giving his right calf muscle, I guess, stimulated by triggering through this glove, through the hand here, and climbing up this wall. And he did it, we tried it before, and to be honest, with his impairment, he did it better than I did. And so the transfer into clinics works. Okay, so here you get this complex definition of motor learning. And I don't want to read it now, you have it in the presentation. But important is that we try to do motor learning by practicing in a way that we can deal with motor memories, that we can achieve long-lasting neural changes, and that we need to practice really a skilled task that is already somehow, or was somehow, pre-programmed on our motor cortex to get it once executed automatically. So motor learning has some stages that should be respected, and we know it from normal treatment, but you can combine it also with electrical stimulation. The theory behind motor learning will not change at all. So we have, in the first stage, in the cognitive phase, it's only important what to do, not how. Quality is less important. When you are more advanced, it is important how to do. So quality gets an aspect. And so you choose also another feedback system. You bring variations in, you tell, okay, now that was good, that was not good, repeat, and you change a little bit the time, it gets longer that you exercise. And at least it is in the performance and autonomous phase, it is important what you do and how you do it. So what the task itself and the quality of the task. And if you shape it in a really good manner, you know that it's automatic. If you can do it and perform the task everywhere under various conditions and with different velocity without losing the quality of the movement, then you are very successful in motor learning. As I told you, stimulation daily 1, better twice or thrice would be for motor learning really effective. And if you can do it only 20 minutes, it's better to do 20 minutes 3 times a day than only half an hour one day. So, however, if you can set it in the setting, yes. If not, do it once, better than nothing. So, so it's always good to combine it. There are some theories behind, and I talked about the different, Martino, about the different learning method. And here is the work I cited before of Wolf. And she is talking about motivation and the intrinsic motivation, and how to perform motor learning with external attentional focus versus internal focus. And the result of it is at least that you should avoid references to body movements. So it would be better to direct the performer's attention externally to a task goal. And I think that was, for me, interesting to read as a therapist, because sometimes we intend to use body movements, or we refer to own body movements. But if you have a disturbed body scheme caused by neurological disease, either stroke, TBI, whatever, and you use your body, it might be disturbing. If you use an external focus, what you did before, then it could be more effective. So you see, it's now, again, I show you pictures how we do it in practice, that you get an idea. Here you see a patient, tetraplegic patient, training the triceps. And first she only did it that we stimulate the triceps and the arm was extended without gravity. Then we performed it against gravity in a later stage. And at least she did it during the standing. In a standing frame, she pushed herself in an upright position. And this picture is not shown here. Then we used it during transfer activities, how she is using triceps in a normal way in her new tetraplegic life. Here you see another example of a patient. He had myopathy, and due to rheumatoid disease, and we did first stimulation and set it up over months, 3 months. We performed it against gravity, and 11 months later he was able to do a better movement with his affected arm than with the not affected arm. We trained him up quite good, and it was a long-lasting effect, and he could keep the situation by training. But you see, it took 6 months after his acute phase to regain the function again. Of course, you can tell me, we never know what would have happened without anything, so that we are always confronted with this argument. But for sure, he was really satisfied, and he trained hard at home, and you see the result here. Here's another result, motor relearning with archery. He was in a situation that he could not fix really good his shoulder blades by lifting up the arms. And he was in rehabilitation, and that was a target or a problem that was a little bit, I would say, limping behind all the other goals. He did a quite good recovery, but here he compensated this movement with the trapeze. And so, and with the trapeze, that is lifting up the shoulders, in contrast to getting down the shoulder blades, doing the depression and medial rotation of the scapula. So we performed it during archery, and he did this 4 weeks, and then he was able to know how to fix also in other movements his shoulder blades. And he was also conducting the stimulation with a foot drop system by his own. When he wanted to activate, he pushed the bottom, and the muscles were stimulated by doing the exercise directly. So with a simple 2-channel stimulator, you can do it with simple devices. Here, motor learning is a little bit more sophisticated. We used it by stimulating, so the target was stimulating the triceps, but he was an incomplete tetraplegic. He could not coordinate well his shoulder blade muscles, the other deltoid and triceps, and even he was not stable in the trunk. So we did a very complex stimulation, and he was triggering his stimulation by pushing a bottom here that was placed at least under this electrode, and he did it, you see it here, and he did it at least by playing tennis with the Y station, lying on his side. He pressed with the elbow here, you saw before, he activated his stimulation, and when he had to do a backhand, the triceps was stimulated and relaxed when he was bending the arm, and the trunk was stimulated at the same time. And yes, it was a coordination task. He has to lift up his leg at the same time. So we tried it, and we try with my team always the same targets. And so, yeah, you know, it was tricky also for us to do. So another example here, she's playing also tennis by stimulating, and she has the activation system here in the hand, and we fixed it, and she was also playing tennis as a tetraplegic, complete one in a standing frame. That is doing transfer activities by getting a better shoulder alignment of the shoulder blade here. We used those stimulation parameters, fixed the switcher in the hand, in the glove here, and all the time he was giving load on the hand. The stimulation was activated exactly then when he used it by lifting up his bottom to do some transfer activities. Here you see an example now where this patient, an incomplete patient, typical central cord syndrome, good legs, bad arms. We once wanted to have the mobile part, with the arm, that she's able to lift up the arm, but at the other hand, we wanted also to give her some stability in being fixed with her hand, giving load on the arm. And we did this stimulation, and you see it now. Hopefully it will run, it should. The arm was lifted up. She is supporting it with her own voluntary activity. Once right, once left. She did it in an alternating way, and we programmed the stimulator according her activity, and then we turned it around when she pushed on one hand, and then she had this loading shift on the other hand, and the other side was stimulated, and we could stop this treatment, and she had an improvement. She was not very acute after some weeks, and she could stop the stimulation with a long-lasting effect. Here we did some static, some trunk stimulation and gluteus stimulation. And when this patient came to us in November and mid of November, beginning of November, he had all his body weight more or less on the part here on the foot where the toe is located, and under the part here. And our goal, and yes, he had back pain by shifting his body weight so much in front of his center of gravity. And then we did stimulation with the trunk, with exercises, and after 14 days, he was quite good able to have, without stimulation, distributed his body weight all over the foot, and we could reduce his back pain. And he was a chronic patient with compensation strategies in daily living. Improving grasping. Here you see the cycle, how we did it to improve. This is a typical tetraplegic hand, and the thumb is disappearing under the or in between the in the hand, in the palm of the hand, and that's not useful for grasping, for using the pinch. And we did twice a day stimulation with exercise. The electrode placement was somehow challenging for all in the stimulation team involved people, but at least he could improve his pinch grasp without having the thumb in palm. And we stopped the stimulation when he improved. Here you see again, he was the forearm pronation was missing, and we trained him with a weight. And you see here the colleague is stimulating very functional, very precisely the muscle. And so he did it 5 times a week, 25 minutes. And also here, he was able to do it. And that's for tetraplegic arm. That's quite important that you have the pronation for every functional task. So here, keep in mind, sensory stimulation, afferent stimulation we see, and it was only sensory stimulation, and we did this drawing experiments, and here you can see it, he did under stimulation, this drawing, and you had this immediate effect, and you see this various colors. In the lowest unstructured, the violet one was before stimulation, then we get this nice green one with stimulation, and the red one lasted immediately after we stopped the stimulation. And that is a proof of an immediate effect you have. But of course, this effect is not long lasting. You have to retrain it. But even with those sensory stimulation, you get into the central nervous system to change movements. Here it was motorical stimulation in a chronic Guillain-Barré patient. And he was, after 7 years of having his stable situation in Guillain-Barré, and he wanted to close his bottoms of the skirt of the shirt, and it was his goal because he hates zippers. He's a man in his 70s and always well dressed, and that was his goal. And so we trained him with stimulation on a regular basis, looking if we could get some compensation strategies eliminated, and if we have some remaining pathways, we can retrain. And yes, we could. He was able to do it after this, and he can still do it. It's 2 years ago, and I meet him on a regular basis in my checks here in Bellinzona in my annual controls, and he's quite happy that he need not to wear zippers anymore. So we have a lot of technology now around, and I like to have these systems, a fascia grasp system. You can really create hand movements if you have an upper motor neuron lesion, lower don't work. But however, in this case, you can create really beautiful grasping tasks, include them in your therapy. The first setup takes a little bit time to create a movement, and sometimes you have to prepare the patient to reduce first the tone to create a good grasping, but it works quite properly. And if somebody has a possibility to use a system for stroke patients, you would be delighted to do so. And I have no contract with the company. So motor relearning, yeah. So this EMG triggered stimulation is really perfect, but please define your motor tasks clearly, what you want to achieve, and use those stimulation setup. Here I can recommend, and you have the slides, you can read it later, that here I recommend to use those parameters. Of course, you can use also 50 Hertz, but be aware a little bit of fatigue. Here's an example of an incomplete spinal cord patient. I applied transcutaneous cervical stimulation, direct stimulation to the spinal cord. And we know that also the spinal cord has a memory and can learn. And this patient is 10 years after injury. He was a squash player before, and he is playing squash also with his incomplete tetraplegia. But he had this problem that he could not grasp the racket in a proper way. The racket was turning around in his hand. He's only playing with a trainer. And then we did it directly in a court. He came from Norway to visit me and asked me to try it out. And I'm also a squash player. So we tried it in the court, and we had an immediate effect that the grip performance was increased, and we could hear it embed in the smash of the ball against the wall. And an unexpected immediate effect was improved side lunges. He could make better steps, and it worked quite impressive here. And yes, he's doing this on regular basis because he's chronic. It has no long-lasting effect. He applies the stimulation half an hour before he went into the court for 30 to 45 minutes, and he can play better. So we will see, it's 1 year ago now, and we will see if he can improve without stimulation. No idea. This is an example of motor learning in the chronic phase 17 years after injury. And if you look to those hands here, you see this denervation atrophies. That's a lower motor neuron lesion. And we could, in the beginning, achieve no contraction, but over a time of 3 months, we could improve some reaction. He was training with a clothespin here, and it was quite amazing how we received after 3 months, and we checked this muscle in advance. It was connective tissue at all. And after 6 months, we had some muscle fibers got back, some pennation angles, and at least he was able, that he was 70 years not able to do. I hope it will work. Yes. He could drive and hold the wheel without using this bottom here, or this, how do you call it, this, don't know the English word, neither the Italian. I only know the German word, it's Knauf, and he could grip the wheel of the car by his own. So quite satisfying and impressive what you see. You can do it also with motor learning here, with first by applying on the muscle. That was a nerve transfer, by the way, by the target muscle, and later with the nerve. And we use the steeple device, where this muscle triggered the stimulation of the other side by using bimanual activity. So, and we combined it in the first phase with mirror therapy, and the second phase by doing a task-oriented training, and not sophisticated. We use our devices, what's possible we have. So not only high technical equipment. So for me, some basics good to know in terms of motor learning, and I'm quite fascinated about the work of Krakauer. And so motor learning is a permanent change in the acquisition of a skill that results from practice over movement experience. So movement experience, Martine, non-taking virtual reality, things that are not belonging to your experience. Motor skills are only learned when they can be performed accurately with speed. That's the theory of shaping. And so the action selection is associated with interactions between the basal ganglia and the motor cortex. So we have this evidence that we can use it. And the quality of movement execution is accompanied by changes in primary and premotor cortex and the cerebellum. And you can see it, and you can support it with electrical stimulation. So just, I will skip this because of time, and we will have a short break. Or do you want to see you, or do you want to continue? It's up to
Maybe we
you.
can have a short break, if you agree. So as Italians, we need coffee.
Yes, so to be honest, I want to have also something to drink now, because, but we can do it shorter because by talking all the time sometimes. Yeah, but it's up to you how long you want. I, of course, provide you 50 minutes, but we can also be back in about 5 minutes.
Luca is the boss.
Luca is the
Can we go
boss.
for 10, maybe?
Oh, that's a diplomat. It's a political solution. Yes, we go for 10. That's perfect.
Okay,
So
great. So
I will shortly take something to drink, be back in about 2 minutes. And if somebody of the audience have questions in between, I'm available when I drink something also for questions.
great, thank you.
I leave it like this and disappear such a second, and then I will be back. Okay?
Okay.
Perfect.
Guys, turn the camera on when you're back so that we know.
That's
You are
that we
here.
know. I could talk even the whole day to you. So nice to have an interesting group. I know it's
Hello, can I ask you a question? Waiting for the others.
of course, Anna.
I'm a neurologist. I work in rehabilitation in Fondazione Dognocchi Milano, and my name is Anna Castagna. I work a lot also with degenerative disease like Parkinson's disease. For instance, people with camptocormia or postural abnormalities like PISA syndrome. And this is a very difficult topic because we tried with the motor learning protocols associated with botulinum toxin, maybe a rehabilitation, but the problem is that Parkinsonian patients learn very, very poorly. So we never thought about electrical stimulation, but maybe because they have surely plasticity problems and also muscular atrophy, and we can see in a magnetic resonance of ultrasound they have fibrosis in paravertebral muscles, and so I don't know if do you have any experience on this or protocols or suggestion, because this is a very interesting field.
Absolutely, I agree. So I have not such a big experience as in spinal cords, but I have some Parkinson patients being treated with electrical stimulation, and I do it for trunk stability and for the gait, that the start-stop problems will
Yes.
decrease.
Mm-hmm.
I made I'm more successful with the start-stop problems when I'm applying a foot drop system only on one side. It's not even necessary on both sides, on one side, and I do for the foot drop in the region of the withdrawal reflex a sensory stimulation, and they don't have this effect anymore. They can walk better. They don't stop. They get like the sensory input. It's like the music. If you apply music to them, they have also this
rhythm.
effect.
Exactly.
And we compared it in 4 patients. And they say, oh, that's perfect to walk, and they are able to walk outside again only without, of course, they have sometimes they have their crutches or whatever, but
Yes, yes.
they don't stop in this regular base.
And
So
also freezing of gait.
Yes,
this typical freezing. Yes, the problem to stop freezing.
So
Yeah.
in those who applied the stimulation, it was really drastically reduced.
Much better.
Yeah,
And how long is the stimulation, and how many times a week?
So the stimulation is during walking. You have to have a portable system, and they need this stimulus by walking.
Okay, okay.
If you switch, and you can see it, if you switch the stimulator off, it starts immediately.
Aha.
So it's like a switcher, on, off, you can see directly. So it has no lasting effect. That's an application for walking.
Okay.
I can really recommend. For posture, you can do, but the effect I see, so they feel more stable after the stimulation for half an hour.
Okay. This is the problems with Pisa syndrome.
I would like, and I haven't never done, but that's in my mind, but I have not so many that I can try on. Do you heard about the Molly system, the electrical stimulation suit?
No, I heard, but never used.
That's
so like a suite, with electrical stimulation inside. No.
Yes, but from Sweden, it's coming. Fredrik Lundqvist invented this. He's a therapist himself and an engineer, and he applied it not in Parkinson's diseases, but in people who have in CPs, to be honest, who have this ataxia, weakness, and hypertonus at the same time.
Yes, dystonic posturing. So,
and he applied it in those, and it's a low frequency 20 hertz stimulation, and you are always below the threshold, the motorical threshold, but it gives them more stability. And I could imagine, I never tried, but if I would have a patient, I would try immediately this suit, just to give them a little input and look if you would use it over time, if you have an effect for 1 or 2 days at least.
Yeah. Yes, I don't know this doctor or physiotherapist. No, maybe we can get in touch to have this address. It would be nice to test on those patients, because I have many, unfortunately.
Yes, and I would really go for it, and to increase really slowly, because they need not a lot of stimulation to get something, to see an effect. If you go too high, they are really fast disturbed, and you get the opposite what you want.
Yeah.
It's like
yes. It's a new research field, I think, because
yes.
unfortunately there is there is a lot of neurodegeneration also in the future. We are expecting, of course, because the aging is increasing, and so of course we have post-traumatic patients, but we have also a lot of patients to rehabilitate with problems with Parkinson's or this kind of features. Yes.
But I would, that's one of my ideas when I have my next coming to me, this problem, that I would go for it and try it with a good follow-up.
Thank you very much. Thank you. Thank you.
So, Luca, do you think we should proceed?
Yeah, we can go. We can start.
So then I will share again my screen. And then open the presentation. Coming. Okay. So now we will go for walking with FES. And I do a little promotion for my own. We have a course in September. You can shortly screen or later in the presentation here this QR code. And we will dedicate 2 days only for walking with FES. And I will touch it only briefly here. So it's a hybrid course, by the way. You can apply for coming to us or also being online. Good. So gait devices, yes, they are all over and such a lot. And if you decide to use some gait devices, you should think about, would it be better to use an ankle foot orthosis or long orthosis for the entire leg or electrical stimulation? And because there are such a lot, you should think what kind of system should I advise and use, and how do I get the access to the system, and can I ensure a structured training with ES before you give such a stimulation device home a patient? And if you have to decide to buy one or to have one in your clinic, then you should also think which of those systems is used most for your clients. And this is not so easy. We have, as portable devices, we have the Phasia Walk, Bioness L300, the Walk 8, the InnoStep, the Incedo. So we have the Oddstock system from the UK. We have a lot, so it's a lot more on the markets. But individual needs require individual evaluation, and that should be not dependent for third parties, or namely the producers of the system. Okay, here it's a very busy slide, but it shows and reflects my proposed or suggested pathway how you should evaluate a patient if the patient has the wish or you think a stimulation device would be good to use, and it takes some weeks. And I would say I need more or less half a year before I buy or I let a patient or insurance buy a system. I want to be really sure that the system is the best for each individual and that the training is set up optimal for the individual. Otherwise, you will have really no success. And I had my lessons to learn, and therefore I recommend. But however, you can see here a patient using the Bioness system for the calf and the thigh, and he is walking with the system quite properly, and he was trained with electrical stimulation for about 2 years before he used it like he used it, and he puts it on in the morning, and if he wants to walk, he's walking with the system, and he is quite satisfied with the Bioness system, and he has no pain anymore by walking, and he had really pain before with his ankle foot orthosis. That was only half an hour for him possible to walk, and now he is making his 2 kilometers and is faster, and he himself said, oh, I have a better quality of life. So it was a long time, preparation time, but he's a good motivated patient, and he did this schedule, and also without stimulation he did a lot, and then we could get him to use this device, and after 3 months he used it already 2 times per day, 45 minutes. Now he's using it the entire day. So preparation is crucial for those, and he came again back because I'm offering my patients having stimulation devices once a year, an afternoon or late evening to come and to try out new systems. And so he was on this occasion, and you see him now here with the fascia walk system walking. And here you see him with the in situ system. He tried out other things, and I will focus on what is what. Here the in situ system is a stimulation system that stimulates under the foot sole the withdrawal reflex. And yes, you can use it for, it's made for stroke patients during the early phase of recovery to elicit the withdrawal reflex. But this is a reflex that gets fatigue, and I'm not so satisfied by using the system. You might use it, as I said, in the recovery phase, but it's not a device you can use over the time, because the quality of stimulation, because of habituation of this reflex, get worse over time, and it needs only 20 minutes and get worse. The fascia walk system is the only system, and I'm really a fan of this system, I have to say, that stimulates the foot extensors and also the foot flexors. That means that in the last or the terminal extend phase, you get a stimulation on the calf muscles to have a better support in bringing the body weight and the load over your stand leg, and to perform a better next swing phase with the leg. So I always say in the application of foot drop systems, the extensors is only half of the story. You need also the flexors for a proper gait. And this system is providing that in a quite good way. So I would say, and he told me when he bought his system, his Bioness system, he's completely satisfied with the system. And he tried it out last year. He said, if I would buy a new one, I would go for this now, because we have only this stimulator here at the calf or at the peroneal nerve, and here he has two stimulators, one of the calf for the foot and one for stabilizing the tide. In this system, by having so many possibilities of electrode choice, I will show you, can do the hip flexion by the withdrawal reflex, and at the same time also the stability in calf and foot extensors. Quite nice, I have to say. Here's another patient with a stroke, and she trained with the fascia system at home. And you see, here you see the dates a little bit. And yes, those systems that you see there require therapy. You can't put a system on a patient and let him walk or let her walk. You have to train the patient. And so the rotation she learned, all the external rotation as a compensation she had, because she's walking since some years with the hemiparesis, that is not reduced by applying a better stimulation for the foot drop and foot terminal stance phase. That needs therapy, and she did her therapy, and after a while she gets better, and now she can correct it, and she's improving slowly her gait, and even she is very satisfied not to wear an orthosis. And interestingly, over time she gets now better even without device, but that's another thing I don't want to touch so deeply. Here you see an immediate effect of a young guy with a hemiplegia. And I do always simple videos just to see. That was, he has a system on, but it's not stimulating. And then Here you see when it was stimulated, he was a little bit irritated. Oh, I got some electricity. And you see it here. He said, quite, oh, that feels funny. And here you see the immediate effect. We turned the stimulation off again. And he said, oh, it's easier now to walk. And that was after his hemiplegia. It was the first trial with the system. So I think that's quite interesting to see, and I want to share it with you, but I also want to share my pitfalls that I had. So I had a hemiplegic female patient 7 years after stroke, and she had, by trying out the Binary system, spontaneous good results, good improvement in gait quality and speed. And then she decided, yes, I use the system and I buy the system. And there was a fatigue problem. And by getting more fatigue by stimulating muscles, the spasticity increased. And instead of an improvement, she had no improvement at all. It was the opposite. It got worse, and she had an increased risk of falling. And I tried to explain to her that she should train and get in contact, and I offered to get in contact with a physiotherapist to do some treatment for her gait and to do a fast training protocol besides using the system and not using the system directly for 2 hours. But she did not, and she stopped using the system after 6 months, and she paid 14,000 Swiss francs. That means, yeah, more or less the same in euro. So it's quite a lot she paid for it. And she was really upset, and I learned a lot. And I never would give it on trust to patients now without being very sure to have a good training around. The other was also a hemiplegic patient, female, 10 years ago, and I tested it, and with a 2-channel stimulator, it was a good result. Then she got a good, she got her Bioness system, and so she had positive results in gait velocity and the foot position, but also she had the fatigue problem, and also she was not doing her training protocol. And I offered to come to us to do her training on regular basis, but she didn't want to spend this time. She only wanted to use the system for walking. And at least we had so many severe discussions that I told her that will never work, that at least she decided not to do any type of stimulation anymore. And at least that were 2 examples. I learned a lot. And therefore, I set up the previously shown pathway. That was right in the beginning when I started to use those systems. And I trusted that patients will take my advice to train, to get in contact with a physiotherapist, to do proper training, what I all documented and gave them home. I do it another way, and I'm much more successful now, I would say, more strict. So just shortly after this, do you have, for the walking systems, any questions? If yes, please tell me. We would have already finished, but I go on a little, if you don't mind. So if you say you don't want to listen anymore, we can stop here. But if you want to, I'm free to, we started a little later, so we can go a little later. So, but it's up to you, you can decide this.
I have another question.
Martino, yes, of course.
One of the concern in using technologies such as electrical stimulation or whatever is the cost benefits, because that takes a long training and it's very expensive. So what do you think it is the balance between cost and effectiveness?
So first of all, I have to say a good ankle foot orthosis that you need for long support. So at least in Switzerland cost about 8,000 Swiss francs. The fascia walking device costs 5,000 euro. So that first of all, so the difference between the costs of ankle foot orthosis made individually for long usage and technical devices, the difference are getting less, so over time. Yes, you are right. If you look to the Bioness system and look to a normal orthosis, that costs less, but to be honest, yeah, you have to follow up them and train them. But if you give them devices like orthosis and put orthosis on patients' legs and let them walk with them, the walk is not even good. You also have to give them therapy and training with the orthosis to use it properly and to have a good result. So for me, and you have no good effect, no extra effect in the brain. And so I would say the cost benefit is worse to do so. But if I would ask for an insurance, they would go for an ankle foot orthosis and reduce therapy. And so they would tell you, no, there's no cost benefit. In my case, in my point of view, if you look to the outcome and to the input into the central nervous system and to therapy and neurorehabilitation, I would tell you, go for it. It's worth to do. Yes, you need to spend a little bit more time and in some devices to pay more, but it's worth to do because the quality of life for each individual, if they can handle it, and not everybody can handle the system. It's not for everybody. But for those who can handle, they have really an improvement. So, but it's an individual decision. It's always depending who you ask. So, to be honest. But yeah, I would say go for it. Good. Because of time, thank you. I will share my screen again. I know we are here. Okay. So I want to focus a little bit on fatigue. So fatigue is really a crucial aspect. You have the difference of having fatigue with electrical stimulation and normal fatigue is that you have no size principle. So normally, when we are physiologically activating a muscle, we use the fibers we need. We use first the slow fibers and only fast fibers are required. The physiological, we take what we need. So if we want to run fast, then we take our 2X fibers in an anaerobic way, but the body is able to choose whatever we need. If you apply electrical stimulation, you use everything what's under the electrodes. That means that you, with each duty cycle, you recruit the same muscles, the same motor units, and the same synchronization is conducted. So at least you get more or faster fatigue and you have to train up. And there are good work by Brass, and he dedicated on different types of stimulation and different electrode placements, how fatigue can be reduced. And I want to summarize this, and I think that's for application quite crucial. So you can do several things to reduce fatigue. So if you apply, and we are talking now only about nerve stimulation, if you apply both electrodes on the muscle belly, then you have to know you have really a very high and fast coming fatigue. So how can you reduce this? Because you are activating under the electrodes always the same motor units. And so you can do it by changing the frequency in one stimulation protocol, that you activate the area less. So you can also change the amplitude a little bit and the pulse duration. But then you have to have stimulators that are possible to program, that they can perform such a stimulation. And to be honest, I only know a few that are able to do this, in that you can write such stimulation protocols in a stimulator. So therefore, I suggest doing other strategies. So for instance, you could try to stimulate once directly via the nerve fibers in the muscle or via the nerve itself. That means you put one electrode on the nerve trunk where several numbers of muscles are innervated, and the other electrode on the muscle belly and a second on the muscle belly. Then you use a splitter and you change your stimulation by once doing the stimulation, both electrodes activated on the muscle belly, and once you have done that for several minutes, it's changing one muscle on the muscle belly and the other muscle and the other electrode on the muscle trunk. So you have the stimulation difference between activating once the H reflex and once only the nerve fibers in the muscle. And so you can a little bit increase the time for using electrical stimulation and decreasing fatigue and training the muscle over the time. So that might be possible. And so, as I mentioned, frequency is really a factor. And by doing those different electrode positions, you can also include different frequencies in the stimulation. I think for me, that's the most practical way with our normal stimulators we use in clinical practice. Of course, if you have the possibility to work with multi-ped electrodes or array electrodes, then you can play in between the different electrodes on one muscle to mimic those different activation of different parts of motor units. But this is not always a possibility. And here's, as I said, my conclusion: these array electrodes for reducing motor unit discharge rates by creating this asynchronous discharge of motor units, and that you mimic a voluntary contraction, or you are using you are varying the frequencies in a single treatment with the electrode position I mentioned previously, that you use a splitter, that you have 3 cables, or that you can stimulate once only the 2 electrodes on the muscle belly, and then one on the muscle belly in combination with the nerve trunk. So that is, for practical reasons, I can recommend. And that's quite important if you do fast cycling over time, that you change this if you want then continuing in fast cycling. Now I want to focus shortly on the phrenic nerve stimulation, respectively of diaphragm, intercostal and abdominal stimulation for breathing. And I think that's quite amazing what you can do. And you see that the diaphragm stimulation can be performed here in this area where you can reach with surface electrodes really the phrenic nerve. You are a little bit close to the brachial plexus. You have to a little bit to navigate around, but you can really put electrodes, small electrodes on, as I will show you. And I use this device, Raise Power, it's called. It's easy for clinical application. And this device is able here to stimulate in inspiration the phrenic nerve, and the active electrode is here where you reach the phrenic nerve. The reference electrode is in the pectoral, and then you have this complex stimulation for expiration on the abdominal wall, and it's a short, strong stimulation for the forced expiration. And the rhythm of stimulation can be programmed individually, and it works quite fine. You see the parameters here, and you see the expiration. The inspiration, it's not visible because we can't see it here on this video, but you see his inspiration and then the forced expiration. And you see the pulse forms on the other side. And he wanted not to have his face in, so a little bit here, you see where the electrodes are sitting. And we use this also, in his case, we used it for weaning. Yes, you see he has a tracheostoma here. Quite amazing device. Of course, if you are familiar with 4-channel devices that can be programmed, you find alternative solutions. You need not such a high sophisticated device, you need only a programmable one, and then you can do the same with other stimulators. So all engineers will do it easily. So if you want to know, it's not always necessary to have patience. And just to give you an idea how a paralyzed phrenic nerve looks like, and you see it on the right side. It's a nice picture, and if you apply the stimulation, you see really differences over time. And here you see it also with the other device. You can use a lot of devices that you can program to do the same for support weaning and for avoiding the diaphragma deconditioning. And I think there are good literature that it's effective on the market. So you see, I gave you this example, and it's really successful, and it's already shown that you can decrease the length of stay in the intensive care unit, and that you also can influence the duration of invasive mechanical ventilation by applying this kind of stimulation. Here, it's for information who want to use it. In clinics, that's just for different targets, how we set up the training for weaning, for conditioning the diaphragma, and we have also it for pre-surgery training before implanting a phrenic nerve stimulator for breathing for an implanted system, that we avoid that the diaphragma atrophies too much. And we have a training schedule post-surgery how to use it. And that's for information for clinicians who want to use it. And of course, we can also do intercostal stimulation if we want to improve breathing. But it's quite important that you have an integrity of the lower motor neuron. If not, this kind of stimulation can't be applied. And be aware you have an irradiation of other trunk muscles, because here, if you use the intercostal muscles, you have something around and over it. You have the abdominal wall. And I can tell you there's no scientific evidence that it will work. I have only clinical evidence that it works. And we apply it with the stimulation and use it for some other reasons. A lot of patients after surgery come to us to do an intercostal training because of the surgery. Some of the muscles do not work. They have an intact reflex arc, but they don't work anymore. They can't be controlled. And so we do it, and I see clinical evidence. And if I want to have sometimes time, I will dedicate with research on it, but I have other research projects ongoing, so I can't do it right now. Here it is, as I mentioned, only for coughing onto the abdominal wall. And if you use switches, you put big electrodes on the rectors, and you see it here, how the muscles are contracting, and you can use it if you instruct the patients to cough, and then at the same time you initiate the stimulation. And here you see it. I don't know if it will work. You see it, look here. This patient is doing. I put 2 slides over. You see the contraction of the muscles in a quite proper way. So it works quite now. We skip this to the end, and I want to proceed to not to waste your time too long. Diagnostic, prognostics, and treatment, how it can be used. I mentioned it before, and that is one of my research that I'm dedicating on, and I'm using electrical stimulation to detect the motor points, or to look if the muscle has an upper or lower motor neuron lesion. And for this, I'm stimulating or first detecting the motor points, and not the sensory motor points, the motor nerve points of a muscle. And you will see it as an example on the upper limbs later. And this point is the stimulation point where an isolated muscle response at the lowest stimulation amplitude occur. And that is worth to do if you want to do some tests for. And I'm using a little stimulator with a pen electrode, and I'm using the classical parameters for nerve stimulation. And how does it look like? I classify it in innervated, partially denervated, or innervated and denervated muscles. And the classification basic is the British Medical Research Council scale. You know, all the therapists know about it, and all the others also. And so you have this ordinal scale from 0 to 5, and I classify them if they have a value by stimulating the muscle 3 and more, then they are innervated. They have an intact lower motor neuron. If you see only a small contraction or small movement, not the entire range of movement, then I expect a partially denervation. And if I can elicit no contraction, then they for sure are denervated. So innervated does not mean necessarily that they are voluntary active. Innervated means only an intact lower motor neuron, not a voluntary muscle activity necessarily. And signs of denervation or degeneration or lower motor neuron does not exclude that there's some voluntary activity in a muscle. That's a tricky point, but important to know. And therefore, we have this nice picture here. And these are the most important muscles in the forearm on the palmar and dorsal aspect for grasping. And I want to focus only on the finger extensors and the finger flexors. So on the EDC and the FDP, and on the thumb muscles, the FPL, and 2 others, the EPL and APL, to show how you can use it as a diagnostic prognostic tool. And here you see shortly how we perform it. It's an able-bodied participant. She's a colleague. You can see how you can detect the muscles. The muscles, the motor points are in relation to the forearm length, and you can find them in every individual you can test. and I did it for over 500. So I'm quite sure that I would also find it in your hands. You can see it here for the thumb and for the intrinsic muscles, just to show. And why do we do this motor point mapping on regular base? So you see, I want to optimize treatment, individualize treatment, and predict the outcome of a hand shape, especially in tetraplegics. And I want to give some support for decision-making processes also for nerve transfers in surgery. And we have a quite big database where we tested, and you see how many muscles we tested. So, and what did we find out of all those? And we had some interesting observations. We saw that denervation is more extended than expected. So normally you have a level of lesion, and on this level of lesion, you expect a lower motor neuron lesion only in the center of the lesion. But we saw that those damages in the spinal cord can't be detected by neurological testing if you don't stimulate the muscles, because the range is by far more than only in the center. And we have interestingly also noticed that flexors show more partially denervation than the extensors. And the arrows are here on the parts where I want to focus on. And you see here you have more partially denervation, and in the extensors for sure not. And if you want to provide a nerve transfer, then it's quite important if you know if you have partially denervation in the target muscle you want to bring a nerve branch in. And the literature also says that in nerve transfers in spinal cords, the flexors have a much worse outcome than the good results in the extensors. So that might be a reason for it, because we can't detect or really good the partial denervation in those muscles. And here you see it, what we detected. Here's the center of the lesion. And normally here the muscles are denervated, but we saw 1 to 2 segments, sometimes 3 segments above and below, also partial denervation in the muscles segmentally innervated from this part. So, and this was quite a good finding. And so we could, by testing the muscles with electrical stimulation, we could identify 4 patterns. And so we see those hands when both muscles, and I'm only talking about the EDC and FDP, as I mentioned previously, we saw if both are denervated, flat hands. If both are innervated, we see somehow a good function, that they can open and close the hands. If the FDP is innervated and the EDC is denervated, we see this classical tenodesis grasp, it's perfect. And in rehabilitation, everybody's intending to have such a hand. And we see if it's vice versa, the EDC is innervated and the FDP denervated, we see this claw hand that should be avoided. And we looked deeper in it, and we could see that we can predict the hand posture and the muscle strength in spinal cord if we do this motor point mapping in a time frame of 4 to 8 weeks after injury. We do this motor point mapping and we detect the voluntary activity if present. And if we know this, we know exactly the expected outcome of the hand shape and the voluntary muscle activity after 24 weeks. That means that we in an early stage can already adapt our treatment. And that's quite good for treatment and for treatment strategies. And we saw a similar situation in the thumb. So we could detect a pattern for the desired hand shape, where the thumb can really be activated by using a tenodesis grasp. We saw when the thumb is in a very slack position, not having a good resistance, can't be used because it does not touch the index finger. And we saw this hand where the thumb disappears in the palm of the hand and can't be used for any grasping. And so also, if you do it right in time, you can prevent this and treat it properly. And what are the consequences? We skipped completely our standardized protocol for splinting and taping the fingers, because in case of an active reflex arc on the flexors, if you put a tape on by the desire having a tenodesis grasp and a close hand, then we activate the firing rates in the muscle spindle by giving the pressure on them. And so the hand, it's getting worse, even more in a claw hand position. So therefore, in those cases, this kind of splinting is completely counterproductive. That is clearly a consequence. And so we can stretch in an adequate way, we can apply electrical stimulation in a proper way, and the task-oriented training can be performed in respective to the expected outcome, at least. So there was a complete change in the treatment strategy in our center after by showing those changes. And yeah, we have sheets here, you see, that can be used on bedside when we want to motor map all those muscles. And it's quite successful. And it would be worse to do it for the lower limbs. So if anybody wants to dedicate on it, please go for it. It's work, but however. So, and here it's also, what do we do with partially denervated muscles, or with a composition in a muscle group where some are denervated or some are denervated. That was what we discussed a little bit previously. So yeah, I prefer to do both, directly stimulate the muscle and via nerve. And if this can't be performed because of time, then it might be also to do a stimulation one the other day, so that you say one day you stimulate via nerves, the other day via muscle. Then you can a little bit have a lower time load on it. And if you can't provide both, then at least stimulate the denervated muscle. Because if you only stimulate the innervated parts of muscles, then you lose the rest. The other way around, you get not the optimal treatment, but you will never lose these fibers who have an intact lower motor neuron. They get a little bit stimulation with, and you will never lose the denervated ones, that they will be changed in connective tissue. So it's worse to do than direct muscle stimulation. So yes, the first steps are really to look lower and upper motor neuron lesion if you want to do functional or structural. That was coming back shortly to my first slide. And if you look to my patients that contacted me first in the last year, then I had 128 first contacts with patients. They wanted to be tested for electrical stimulation. And in those, I found in 49% lower motor neuron lesions, and that's quite a lot. And also in 13%, they had combined lesions in one muscle. And so it's worth to test them carefully to apply the correct stimulation. Otherwise, you are stimulating without effect that you want. And yes, stimulation of lower motor neuron lesions, it's worth to do. There are research done. So in Italy, the group from Hugo Carraro in Padua does a lot of stimulation in lower motor neuron lesion. They, years ago in the 2000s, they set up the RISE project for paraplegics, for getting better muscle volume in the lower limbs, to do stand up and some walking exercises. And they could prove quite properly an increase in epidemical thickness. And they could show that there was a re-innervation after peripheral nerve injuries, that the muscle could increase in the cross-sectional area, and also that there was long-term de-innervation that could be converted in quite normal muscle structure. So there are a lot of advantages to do, but be aware, if you have a chronic or if you have a complete lower motor neuron injury and you want to reach those effects, or even only muscle structural effects, you have to use it for lifelong stimulation, like a medicine, and clarify with your patients if you want to do it or not. If it's worth for the individual that they haven't benefit or only a time expenditure. So in this patient group where only lower motor neuron lesions are present, you divide in between acute and subacute phase in the first 2 years, and after 2 years you call them chronically. And so also your targets are a little bit different, but increasing muscle volume, increasing thickness, and the enrichment of contractile muscle fibers is possible also in the chronic phase. We don't talk about re-innervation then, of course. There are limits. Here is mentioned what happened in a muscle after the de-innervation process, and that will happen in the first years. It starts by seeing some muscle fibrillations, and in the very beginning you can elicit a contraction even in a lower motor neuron lesion via nerve, and in the first 14 days, and at least after years you see this replacements from muscle fibers into fat tissue and connective tissue. So, and you go through this development in a muscle. And as I mentioned, Hugo Kern and Hugo Carraro have done really brilliant research with muscle biopsies, and they recommend in the lower limbs an early start with stimulation. And I did research on the upper limb, and I can underline this statement that you should do it. And we did this research in the upper limbs, and you see here this picture of a completely first interosseous muscle in the hand, de-innervated the structure, and you see the same muscle after 6 months of stimulation, and you see the structure, how it could be restructured again. And we did this research, and it was quite amazing what we could see during a stimulation period of 12 weeks. What we could regain, we could see it in the first interosseous, how the muscle thickness increased and how the pronation angle widened again. That is a surrogate for the muscle thickness, the direct one, and we could see it also in the forearm muscle, in the extensor carpi ulnaris. And even more, by doing this, we could predict, if you start the stimulation at one point, we could predict at least the increase in muscle thickness after 12 weeks. And that means that if you start a stimulation with a patient, you can tell him that more or less how much they will benefit from a stimulation. And that's worth to do. And even the patients were very satisfied, and we did questionnaire if they want to use it on, and only a few said that they think that they would not use it for long-term utilization. And out of 20, only 3 mentioned that they won't do it, that the time expenditure was too much. So also this is worth to do. At the end, only 5 minutes. I want to give you some tips and draw a conclusion. So I think we should reflect our development, how therapy changed over time. We look yesterday, we did almost classical treatment with hands-on. We used our classical method, PNF, Bobart stretching, strengthening, all those kinds. We used it, and I will not say we should not use it anymore, but now we do something else. We put those hands on, and we know that also hands off in combination with evidence-based treatment strategies, including electrical stimulation, robotic devices with electrical stimulation, brain interface technology, transcutaneous spinal cord stimulation, virtual reality features can benefit and can enrich our classical methods. And we are open to combine everything. And we have this beautiful group of engineers that should be included in the rehabilitation process that can provide such lovely individual things that we can use. And I think that's, for us, a big advantage. Of course, we have some hurdles to overcome. So the implementation of all technologies into a rehabilitation process, and we have to know how to combine it with our traditional concepts and therapists sometimes are not so willing to challenge themselves with technology. And I'm allowed to say so, I'm a therapist. So, and we have to have serious anatomical skills. And of course, we should be technological curious, what is required. And here, group activities, as we discussed also, versus individual treatment, that should also be done. And I'm not sure that sometimes group activities might be more successful than an individual treatment for several groups. Sorry. So, if you want to read something more, I can recommend both books here. And I think they are quite good to get more insight about electrical stimulation. And of course, I know we have all the evidence of learning processes, how much it needs, and we have our duration of rehabilitation. And all this is cost-benefit relation and cost-effectiveness discussion. And yes, that's a challenging process. Once is slow, and we know it's slow, and this is fast. But I'm sorry, we can't do our best only by having time. And I will fight against insurances to have more time, because evidence is different from what we get in a new rehabilitation setting. So that's obvious. And perhaps we can find other possibilities in outpatient services or in home-based therapy. I try to figure out how we can improve, but I have not the holy solution. And that's only informative how we do it in our FEST center, how I try to follow up patients and how to set up a long-lasting program for patients. And I'm also willing to do online consultations. And it works quite properly, I have to say. It's always possibility for improvement, but we are on a good way. And last but not least, I'm so lucky, and I have the privilege to work with a team, because it's so important if you want to improve that you have a team that is balanced and highly motivated, curious, critical, and inspiring. And in our team, the word "but" does not exist, because "but" is a killer of all innovation. And we have humor that plays an important role beside of our professional competence. We have fun to work. And now it's my pleasure to give you the assignment, talking about fun. And I would like to ask you all to send a 2-minute podcast about the 3 most relevant aspects you heard today. Include if and how you could imagine to implement electrical stimulation in your daily work, and mention changes, challenges, and barriers you expect or you already experienced. And load it up, please, this podcast until the 13th of October to the online platform you know all about where. And this is my end, and I'm sorry we are a little over time, but hopefully you enjoyed, and you can ask me now or later at any time you want questions, of course. And I was quite fascinating of your group, that you had a lot of interest, and I appreciated to talk to you.
Thank you, Ines. Thank you very much for your lecture. It was really inspiring. I let the floor to the other students if you have questions or curiosities.
No, they are hungry now.
Could be.
Yeah, of course they are. It's me too. So I can completely understand this. That's not the point. I would rather like also to do some, I don't know if you are working on your daily practice with electrical stimulation, but I would really like to demonstrate also on you how the differences are and how the testing is done. That's quite an amazing part, I think. And in every neurological disease, if you see the principles of electrical stimulation, you can use a part of it and you can modify it individually. And then you decide if it's worth to use it or not. And so there are a lot of opportunities to do so. But it has to be done individually, at least. So may I ask, did this, because it's the first time I give this lecture in front of you, I do it in Zurich at the University for engineers, but I only focus on artificial breathing, and I do it in Basel and Bern for physiotherapists and occupational therapists in the master program. And I want to know from you, does it cover your expectation of the lecture, or do you have wishes or desires what should be done and not done? Was there an overlap from other information you got? Should I skip something, put in? So please feel free to tell me, because that's always, I have an idea what I want to let you know, but you have, Who wanted to talk to me? Nobody?
If you want, I have another question.
Yeah, Martino, of course.
It's always me. I'm sorry. What do you think about the triggered electrical stimulation? I mean, if you improve a muscle strength and recruitment, can you switch from outside triggered electrical stimulation to an auto-triggered electrical stimulation?
To an EMG trigger, yeah, I do. So I think it's a quite good idea to do so. I do. I'm not so satisfied sometimes with the EMG systems. They are not so precise. The one that is really good and precise is from the new system from the Stivel Pro system. That's quite precise. But the others, you put the electrodes on, and even if a neighboring muscle is activated, then you start the stimulation with this EMG trigger, and then you do not train what you really want to train. You're a little bit beside. And that's my main concern with the EMG triggered, with a lot of those on the market. And I only know at least one that is more precise that I mentioned already. But that has to be tested. And if you use them in clinics. So I tested a lot and I was not satisfied with them because of the incorrectness of having signals from all over. So that's the only thing. But at least the theory is good. Yeah, Martina?
I was thinking about using it in winning processes where you can maybe detect an activation of inspiration and then add electrical stimulation to have a good ventilation. That's all.
Absolutely. And you could technically, that would be possible. Yeah. And you do it with the normal respirators. You do it already. If somebody is triggering, then you have this triggered ventilation. And with this triggered ventilation, you might, but we have a lot of engineer colleagues sitting around. They can suggest you something. You should put a sensor in and then activate also the stimulation more or less. Should be possible technically. Completely agree. But I don't know a system on the market that can already do. Mm-hmm. Other comments, wishes? Feel free. I'm not sensitive. You can tell me everything.
Hi, I'm Salvatore.
Salvatore, I can't see. Wait, I can't see you. Yes, I see you, Salvatore. Yeah.
Okay, I thank you for your inspiring lecture. I have just one curiosity about vagal nerve stimulation. Do you have
about? Wait. I can't hear you properly. So about the.
Do you have can you hear me?
Yes.
Okay. Do you have an experience about vagal nerve stimulation? And what do you think about in clinical?
Okay. No, I have no experience. I talked to Michael Baumberger, our chief clinician, and we talked about for our people for obstructive dyspnea to use this vagal stimulation overnight. And probably you are thinking about this, perhaps, or what's your idea?
There are some systems, for example, transcutaneous auricular nerve stimulation.
Yeah, exactly.
Not invasive in this case.
Yeah. So not in the, I have no experience, but I think at least for, it would be a good thing to follow up. Yeah. And if there are surface possibilities, yes, better than the invasive ones. Yeah. But sorry, I can't tell you from my own experience. Theoretically, I would say yes. Mm-hmm.
Thank you. What do you think about the invasive stimulation in general, also for muscle recovery?
Invasive stimulation. Mm-hmm. So I think if you have an implanted system for a stable situation, then, and it's working quite good, I would prefer always the implanted systems. That's reality. So we know it from the all the diaphragm stimulators. So we know it from the one that is directly with the nerve cuff electrodes at the phrenic nerve. We know it from those who have the electrodes on the diaphragm. So there are two different systems implanted, and that's perfect for them if they can use it. We know it from the Brindley stimulator for avoiding the bladder. That's an implanted system that works for over years. So spinal cord can avoid bladder and bowel by using the stimulation implanted. So it's really an advantage. We know it from neuromodulators for pain, for those who it's working quite well. So for the ones who have now the long electrodes for spinal cord stimulation for walking, we are not at this stage that we can recommend or say that's the final solution. We are here, we are on a good way, but here we are in research. And so I only want to raise a little bit awareness what is shown in the media and what is reality in the outcome. So we are in a good way, but not on the stage that I would recommend for the other devices. We are already over this, and that's quite perfect. So if you find a good system for implantable systems, and that's quite good, I would say it's always better for everybody. Mm-hmm.
Okay, thank you. Just the last question. You talked about the ultrasound. Do you have some suggestion to use in clinical practice? For example, are there some features that I can check during my clinical practice? For example, you talk about the pronation angle. What do you think about it? What can I use in clinical practice? What are the most effective features that I can check during my visits?
Okay, so you're not talking about other possibilities in ultrasound, you are talking about in general.
No, I'm talking about for the combined with use of electrical stimulation for the effectiveness of electrical stimulation, obviously, in this case, so, not in general.
Okay, so I control my success in electrical stimulation mostly with ultrasound, but also with EMG, surface EMG. So, and but if I want to have a control about morphology of a muscle, then I only do the ultrasound. So I have a device during my work. I can use it spontaneously, and I do it for to be honest, I do it for research and for insurances, and now also for patients, because if they see the differences, they are more motivated. We do it also for motor learning or for better access, for better voluntary activity with EMG. And we show how the EMG activity by doing exercise or movements was by the beginning, and when they did their stimulation and all the exercises, and then they came again, and we do it as a proof. Is the recruitment better? That we can measure in EMG, that are the most we do, the most assessments. Mm-hmm.
You think EMG is better than the monitoring with ultrasound for you?
No, you can't. So you can't compare it, because if you do long pulse stimulation only for changes in muscle structure. For instance, if you have a complete paraplegic person with a low level injury, and you want to increase muscle mass in the gluteus muscle to avoid pressure ulcers, then they never can't activate the muscle by themselves. So you have to have a look into the muscle structure. So that one covers muscle structure. Of course, you can also see contractions in ultrasound, but that can be also covered by the EMG. That can be both. But structure only, you have to look. Mm.
Thank you.
Mm-hmm. Other? You can write me. You have my email. If somebody wants to know something, you can write me. That's not a problem.
Thank you very much, Ines, for your time, availability, and the lecture. So if there are no other questions, I think that we can close the morning session. so that we have a lunch break.
A shorter one. I reduced your lunch break. I'm so sorry.
No, don't worry. Yeah. So for the students, we connect